Good morning. I'll just wait for the cue as to when the introduction will start. I'll go on mute for the moment.
Good morning, everybody.
Good morning.
So, by show of hands, can everybody hear me? Perfect. Thank you, thank you, thank you. We'll get started here in just a second with Dr. Hakimi.
Hi, can you hear me okay? All right, I'll go back on mute until we're ready.
Good morning and welcome back to the fourth and final day of our 123rd annual convention. We hope you've had a wonderful time and learned new things. Our next lectures are coming to you from out of our area and joining us virtually. Our first speaker, many of you may know, Ryan Hakimi, DO. He is a neurointensivist and the director of transcranial Doppler ultrasound services at Prisma Health Upstate in Greenville, South Carolina. He is a professor in the Department of Medicine, Neurology at the University of South Carolina Greenville School of Medicine. Previously, he was the first neurointensivist in Oklahoma and the founding medical director of the OU Medical Center Neurosciences Intensive Care Unit. He was a United States Department of Energy Applied Health Physics Fellow, graduated from the Michigan State University College of Osteopathic Medicine, and completed his medicine internship and neurology residency at Michigan State University. He completed a 2-year neurocritical care and stroke fellowship at Duke University Medical Center. He is board certified in neurology, neurocritical care, neurosonography, and a neurovascular specialist. He was the first fellowship trained DO neurointensivist and the first DO to be designated a fellow of the Neurocritical Care Society. Welcome back to the OOA, Dr. Hakimi.
Thank you so much. Thank you for that generous welcome, and thank you for our conference organizers and Audrey. It's such a pleasure to be back, although virtual, in Oklahoma. I started my career there and was there for 7 years. My children were born there, and it always has a very special place in my heart. And I'm glad to see that the OOA is doing well. I was a member for a number of years and a participant in these conferences, and just delighted to be here. And thank you so much to all of you for your time and attention and for thinking of me. So today we'll be talking about ischemic stroke risk management for primary care providers, basically how to take care of these patients when they come to your office. I don't have any relevant disclosures. So we're going to review the prevalence of stroke in Oklahoma and the United States as a whole. We're going to discuss 7 modifiable risk factors for acute ischemic stroke. And we're going to detail how healthcare providers can treat and impact the 7 modifiable risk factors associated with acute ischemic stroke. So just some basic epidemiologic data. The most recent data that the CDC has available is from 2021, most likely because COVID delayed the publication of the subsequent data. But as of now, there's about 800,000 people per year with a stroke, 1 every 40 seconds, and every 4 minutes somebody dies of a stroke. So it's still has a tremendous burden on our health system. Here's where it's important to identify this third point here. So individuals who've already have a stroke have about a 25% chance of having another stroke in the future. And historically, that's been in the next 3 years. So if you have a stroke today and you're cared for in the hospital and subsequently you go to your primary care doctor, it's important to explain to somebody that this is not a one-time deal. And 1 in 4 is very significant. So keep in mind that 87% of strokes are ischemic strokes, in which blood flow is blocked to the brain in a particular vessel, whereas about 13%, a much smaller number, are related to bleeding types of strokes. So here is a map of the country's highest death rates from stroke. And notice how they're all in the southeastern part of the state, part of the country over here. So currently in South Carolina, we have actually a much higher stroke death rate than in Oklahoma here. So this reminds me of a joke that folks used to say when I was in Oklahoma. They used to say, at least we're not Arkansas. So right next to us is Arkansas, and you can see that they're in worse shape than Oklahoma. Here's some statistics relevant to Oklahoma. So Oklahoma has the 3rd highest death rate from cardiovascular disease in the country. And heart disease, as with everywhere pretty much else in the country, is the #1 killer, and stroke, unfortunately, is number 5. And when you look at this pie of other things, you see that obviously cancer, just again like other states, is a very important part of the contributors to death. But if we look on this side, on the right side of the screen, we see that the smoking rate is higher in Oklahoma, unfortunately. The activity rate is less, obesity rate is higher, and so on and so forth. So a lot of these things are still major challenges for all of us who are healthcare providers, in particular, those of you that continue to practice in Oklahoma. And if we break it down by county, here's Oklahoma County right here. Interesting to note that and so in this health outcomes, being #1 is good, and being number 77 is poor. So the darker portions are the less healthy parts of the state. Interesting to note here, I wouldn't have known this, but in the Panhandle region are actually the healthier people, which seems interesting because they have a lesser access to healthcare, but perhaps on the activity side, they're closer to the mountains and so on and so forth. So the American Heart Association, American Stroke Association have really simplified all of their recommendations into this one pictorial graph here, where, and I would encourage some of you to consider just having a picture of this posted in your office, or having a pamphlet or something like that, because it really summarizes what every individual needs to do, and how we as healthcare providers can improve the probability of a better outcome for our patients. So if we start up here, this is supposed to be a glucometer, obviously glycemic control. This is diet and diet here, weight control, exercise, not smoking, blood pressure control, and lipid management. Now we're going to break down sort of how do we approach these various entities within stroke. And so to begin with, let's start by defining what TIA is. You know, those of you that have been in practice for a number of years, people used to call them mini strokes, but it's important to note that if somebody has a TIA, they cannot have any symptoms permanently. So if they have any symptoms, that's a stroke. That's not a TIA, even if the symptoms are mild. So it's transient ischemia, basically reduced blood flow to the brain, spinal cord, or retina, leading to focal neurologic deficits without infarction. So MRI imaging is usually normal in these individuals. And the symptoms are brief. They're less than an hour. They do have a risk for a stroke in the interim next couple of days. And that's why people need to have urgent medical care to be evaluated to see what can be done to prevent them from having a stroke. As with most things, treatment starts with antithrombotics, usually an aspirin, and you need to figure out what is the cause. So when I was in training, there was very comparatively less thought given to why the person had a stroke, as opposed to trying to determine that or prove that the etiology is one thing versus another. And at the time, the argument was, well, you're going to give them an aspirin anyway. Why do we need all this sophisticated testing? Well, it turns out the treatments are very different, and we're going to discuss that in a little bit. But everyone who has transient neurologic symptoms needs structural brain imaging. So a CAT scan, rule out a hemorrhage, rule out a brain tumor, rule out a stroke, whatever it is. MRI is obviously a better test, but is less available. You need vascular brain imaging, which most commonly nowadays is a CTA head and neck. MRA head and neck can be done. Carotid ultrasound is acceptable as well. And transcranial Doppler ultrasound, which is similar to carotid ultrasound, but it's looking at the intracranial vessels. And you need some cardiac imaging, transthoracic or transesophageal echocardiograms. So recognize that many times the patient has happened to have had an echo, let's say even a short time period before, a month ago, a year ago, 6 months ago. You need to repeat that imaging because what you're trying to determine is, does the patient have an intracardiac thrombus, which absolutely would change your management because that would be somebody you would anticoagulate. So if the patient had an echo when they didn't have symptoms or before any symptoms, that's not unfortunately very helpful to you. So you need to repeat that. And then hospital observation versus TIA clinics versus hospital admissions. And these really depend on the resources that you have locally, how your health systems organize things. Used to be all of these patients got admitted for 2 to 3 days. But that's becoming more uncommon because their testing can be done relatively quickly. And once you exclude a stroke, they often can be discharged, provided that you have appropriate follow-up organized and their medications and so on and so forth. So primary prevention of stroke. So What do we do to prevent a stroke to begin with? We got to identify the individual's modifiable risk factors from that little pictorial that we talked about. Lifestyle modification, we can all afford to lose some weight and exercise more, myself included. Medications to reduce stroke risk, such as aspirin, without any other indication is not supported. So 10 or 15 years ago, anybody over 50 who happened to be overweight, they were just prescribed an aspirin to prevent problems. That is no longer supported by scientific evidence. And in fact, surprisingly, when you look at a large population of people in which we used to practice that way, their GI bleed risk is not trivial when you just give every human being an aspirin who happens to be over 50, whether they have stroke risk factors or not. So that's not a good idea to do that. And then surgical or endovascular treatments, including treatment of asymptomatic carotid stenosis. So you happen to order a test. Let's imagine you even ordered a CT of the chest for somebody, and they very often can capture they might get part of the carotids in that at the top of the image, and they tell you that the person has 90% stenosis. That's somebody who would benefit from a procedure irregardless of whether they have any stroke symptoms or they've had a stroke. So just remember 90% with asymptomatics, and that's from the NASA trial from early 1990. Identifying modifiable risk factors through your history and physical exam. Obviously, previous history of TIA. Check the blood pressure at every visit to identify hypertension. Even for those of you that are not primary care doctors, it's very useful to contribute to the medical record by simply charting a patient's blood pressure. So if you're an orthopedic surgeon and the blood pressure is charted in the electronic medical record, when the patient does see their primary care doctor, they have more data points by which to make a decision. And so checking the blood pressure at every patient's visit is just probably a good practice for all of us to implement. Check the pulse rate and assess for rhythm for possible AFib. Identifying the patient's weight and BMI, and listen for carotid bruits for possible carotid stenosis. Now, these last several are obviously not for the orthopedic surgeon example, but the point is that hypertension is such a treatable condition. There's 100 million Americans with hypertension, including every one of my family members, and you have a 1% risk of having an ICH, intracranial hemorrhage. So making sure that we identify individuals who are hypertensive and initiate therapy as soon as possible is very important. Hemoglobin A1C or fasting blood glucose. So when I was in Oklahoma, I think my second or third year there, maybe 2011 or 2010, the state identified that 1 in 6 Oklahomans has diabetes. And so at the time, it may have changed since, but Medicare approved testing A1C in patients irregardless of what they came to medical care for. So we started screening everybody in the hospital for no matter what they were there for with an A1C, and it was getting paid for so that you could identify diabetics and treat them sooner. Lipid panel assessment for hyperlipidemia, obviously. And then, so we identified things in our history and exam, and then there's things from radiologic and cardiac studies like we talked about briefly earlier, our structural brain imaging, our vascular brain imaging, and our cardiac imaging. And I don't need to share this slide because you're probably the experts of hypertension management, even more so than I am. We talked about the risk rate for an ICH for patients who have hypertension. So there's 1 million intracranial hemorrhages per year in the United States. And that reflects that 1% of the 100 million Americans who have hypertension. You need to be a little bit more on the aggressive side. If somebody's blood pressure is outside of the norm, a very relatively brief time period to give them opportunity for weight loss, diet, exercise, so on and so forth should be undertaken, because most often that's not going to resolve the issue. So if after 6 months the patient's blood pressure is still in the 140s, they need medication so that they don't end up like one of those individuals with an intracranial hemorrhage. Role of diabetes, we talked about a little bit. So the important thing for you to be aware is that the risk of diabetes and stroke is actually higher in African Americans. So 37% to 42% in that between Caucasians and African Americans have a risk for acute ischemic stroke. So that's incredibly high. So think about all that 1 in 6 Oklahomans that have diabetes that come to your office. Now, if you take that one person, they basically have a 30 to 40% chance of having a stroke. That's a very high number. So that behooves us to be very aggressive and take care of these patients. So this next part says, screen your patients, and you'd be surprised how often they're diabetic and you didn't even know. Hyperlipidemia management. So statins are standard of care for stroke patients. So irregardless of what your actual LDL is, you have a benefit from a statin. So there's one exception to that. That's people with an incredibly low LDL, typically less than 50, who are started on max dose statin. They do have a risk of intracranial hemorrhage, but that's pretty uncommon that we see somebody who without medicine has a LDL less than 50. So that's an outlier kind of patient. But think about the number of individuals that we see that have an LDL that are around 100. Well, if they have those stroke risk factors, that's somebody who would benefit from lipid management and trying to get their LDL less than 70. Another thing that you might see is that a patient comes to the hospital and they have a stroke, and somebody increases your statin therapy. So maybe their LDL is 75, or even if it's 68, let's just say, and they're started on 80 milligram max dose atorvastatin or 40 milligram rosuvastatin, what we call high intensity statins. There's evidence that for the first 30 days following a stroke, there's benefit of high dose statin outside of lipid lowering for patients in terms of their outcomes. And so what we do is basically every human being who has a stroke, unless they're one of those rare people with a LDL less than 50, gets high dose statin in the hospital. And our objective is that when they follow up with our outpatient colleagues, that's where then somebody reevaluates their lipid profile, their liver function, and their CK, and then determines, okay, now we're outside of 30 days, what dose should we keep them on to keep them under 70? We all know cigarettes are bad, and we continue to have difficulty with our patients quitting. But there are some medications we're going to discuss in a little bit later in the presentation for that. How about the role of carotid stenting versus carotid endarterectomy? So there have been a number of trials, but these are the ones that stick around when we explain things to patients. So 3 prospective carotid endarterectomy trials showed that if you were symptomatic, meaning you had a stroke or TIA related to the vessel where you see the 70% stenosis. So if a patient had a right MCA stroke and they had 70% or greater stenosis here in their right carotid artery, that would be somebody that would warrant surgery or stenting. If it's on the contralateral side, but they had a stroke on this side, that's where you have to wait until it's 90. So in this group, in the asymptomatic group with a greater than 70, but they're younger than 75, they would also benefit from a procedure as well. The idea there is that if you're 50 years old and you have 70% stenosis, but you have no symptoms, it was incidentally discovered, you got a lot more years to live. And so that 70% is probably going to become symptomatic. And therefore, intervention, surgical or procedural intervention would be worthwhile. So there's a relatively famous trial, now probably in the neighborhood of 20 years old, carotid revascularization endarterectomy versus stenting, CREST. So things to jump out here is 2,000 patients, 117 centers, where they compared carotid endarterectomy and carotid stenting. And they evaluated for stroke, MI, death, complications, so on and so forth. There was really no significant difference in a 4-year rate of primary endpoints between the two procedures. Now, the caveat is these were experts, not only expert vascular surgeons doing carotid endarterectomies, these were experts in neuroendovascular care doing the stenting. They're not just the run-of-the-mill centers. And specifically, MI was more common in the CEA group, whereas acute stroke was more common in the carotid stenting group. Now that makes sense because if you're doing carotid stenting, most commonly you're going through the groin and you might knock off a plaque or something like that. So there might be a periprocedural stroke versus somebody who has a carotid endarterectomy. They're working locally and therefore has a lower likelihood of stroke. And in the end, they were the same. The N was the same, but this is what the consensus is in terms of clinical practice. So if your patient is less than 70, and there's a greater benefit from carotid stenting because they have probably less atherosclerosis. So, excuse me, a lower likelihood that when the proceduralist is doing that catheterization that they're going to knock something off. And if your patient is older than 70, that's somebody who would benefit from a carotid endarterectomy. Factors that should influence your decision, it absolutely matters who's doing the procedure. So I wouldn't just send my patient to the most local place where they can do carotid endarterectomy or carotid stenting. I would want to know what kind of volume they have, because these are a volume-based outcomes. That's been shown over and over. Places where they do less than 10 carotid stenting cases, they have the highest complication rates in comparison to those that are doing 50 or 100 cases, high volume centers. Vessel accessibility. So if some people, their carotid bifurcation is above the angle of the jaw. So the internal carotid artery is actually behind their mastoid. So you can't get to it. It's carotid endarterectomy is not possible. Similarly, if somebody has a really, really fat neck, that's somebody that the amount of dissection that you're going to need to get down to the vessel is going to increase your surgical risk. So knowing where the lesion is in comparison to the patient's jaw really does impact your decision-making as to which procedure you would favor. AFib, well, we all know that AFib is terrible. And it's very common, unfortunately. So more than 75,000 strokes per year are attributed to AFib. Now, paroxysmal AFib counts as AFib in terms of stroke. So if somebody gets a 30-day Holter monitor and they have one 10-second episode of AFib, they need anticoagulation, okay? Because you're not going to, you don't know if that frequency is going to be higher, and you don't know if that 1 10-second episode is going to cause a stroke. So oral anticoagulation is standard of care. We know about warfarin and its drug-drug interactions, drug-food interactions, INR monitoring, which is a pain in the behind, and the risk of bleeding. So in 2010, Dabigatran came out and touted as, life-changing because it doesn't require patients to have laboratory monitoring. Trial was massive, 18,000 patients, and the goal was just to demonstrate non-inferiority to warfarin with an INR of 2 to 3. Now think about that. In terms of the patients that we see, how often are they actually in their therapeutic window of INR 2 to 3? So if you had to accumulate, 9,000 patients who are on warfarin who have an INR of 2 to 3, that's pretty darn hard to identify. The vast majority of our patients are not in the correct INR range. And so therefore, this drug in reality has a greater benefit in comparison to warfarin, because most of our patients have a hard time being in the right therapeutic range. So in the study, they looked at safety outcomes, systemic embolism, and I'll cut to the chase basically. That both doses of dabigatran were superior to warfarin as a primary outcome. Hemorrhagic stroke was rare in all 3 groups, but statistically significantly lower in the dabigatran group. So if you look over here, it's about 3 times the risk of stroke in the warfarin group, the hemorrhagic stroke, I should say, in the warfarin group in comparison to the dabigatran group. And major bleeding complications, around 3% for warfarin, around 2%, 2 to 3% for dabigatran. Not super different between the two. Cost, so back in 2010, that was a #1 deterrent for people to use prescribers to order dabigatran, because it costs so much more than warfarin. But as time has gone on, that has the cost has come down tremendously, and the cost of somebody coming to your office or to the lab to have their INR checked, that cost has gone up tremendously. So it's actually cost efficient, believe it or not, to prescribe an oral anticoagulant that it does not require monitoring. Well, in terms of sort of an update, this is what we have currently, and we use these much more often than we use dabigatran, mainly apixaban. Apixaban has really the stroke market. They've shown a slightly lower risk of intracranial hemorrhage than rivaroxaban. And so most people in neurology or neurocritical care prescribe apixaban. Now, we don't go and, if somebody's on rivaroxaban, we don't go and take them off of it if they're doing fine and they don't have any issues with it. Edoxaban is primarily used in Japan. I've never personally prescribed that. They're all equally efficacious as warfarin. They have less life-threatening hemorrhage, no drug monitoring, and it's a fixed dose. But keep in mind, it's contraindicated in valvular AFib and severe kidney or liver dysfunction. So valvular AFib, which is comparatively less common, that's the one time that your only choice is to give the patient warfarin. Severe kidney or liver dysfunction, that's a gray area as to what constitutes severe. I would say that if somebody's creatinine is 2 or greater, I probably would not prescribe them a direct oral anticoagulant. So when we want to think about what bucket does our patient fit in, we have to first figure out the cause, and then once we figure out the cause, that will guide our treatment. So older patients, usually large artery atherosclerosis, By large artery, we mean large vessel, or the carotids, or the middle cerebral artery. Small vessel disease are those little tiny branches that come off like the capillary level, or a distal branch of the, for example, middle cerebral artery. And then when we think about younger patients, we think about hypercoagulable state and connective tissue disorders. And then either group can have cardioembolic ones. They can have paradoxical embolism, such as if they have a patent foramen ovale and they happen to get a DVT and the thrombus can cross. And low blood pressure, hypotension, causes cerebral hypoperfusion. So somebody, for example, simply having surgery, anesthesia unfortunately drops your blood pressure, the result of the medications that are used, and somebody might not send enough blood flow north, and therefore they can end up with an ischemic stroke. So this is the sort of order of medications that I personally prescribe. Of course, it depends on what other medical conditions the patient has, but in terms of hypertension, I always start out with an ACE inhibitor or an ARB, move my way to a beta blocker or calcium channel blocker, diuretic, hydralazine, clonidine, minoxidil. Now, I recognize that diuretics for most people is at the top of the list. The problem is in our world of neurocritical care, managing the patient's fluids in the hospital environment is very different than people managing their own, PO intake. That's why in the hospital environment, diuretic is moved down here, because we don't want to dehydrate the patient and cause other problems. But in an outpatient setting, many times you're going to start with a diuretic group. Hyperglycemia, we know that acute hyperglycemia associated with a stroke actually worsens clinical outcomes. So those individuals who come to the emergency department with a blood glucose of 350 and they have a stroke, we already know that they're going to have a worse outcome unless we get that blood sugar under control quickly. So we shouldn't be so conservative and not use insulin infusions on these individuals. We should be relatively aggressive. In particular, when we see their hemoglobin A1C come back at like 12 and 14, it's relatively unlikely that that brief period of NPO is going to make them hypoglycemic. However, we don't have the same glycemic goals as, for example, outpatients. So current recommendations are keep your blood glucose less than 150 in the acute setting here in the hospital. Long term, this is what I tell our patients: for every 1% increase in your A1C, so if your A1C was a 6 and now it's a 7, or if your A1C was, or a better example, if your A1C was an 8 and now it's a 9, you now have a 10%, 10 to 12% increased risk of stroke just from that 1%. And of course, we want their outpatient A1C to be less than 7. Now, your lab may have a different cutoff, but it just depends. But the bottom line is you want their A1C to be normal if you can. Statin therapy, there is excuse me, good evidence that if statins are not continued during the hospital admission, there's, by the time they see the primary care doctor and it comes to somebody's attention that the patient's not on a statin, then they have worse outcomes. And so every patient that comes to the hospital is started on a statin, with the idea being that hopefully they're going to be seen in that shortly after that 30-day time period to reevaluate what dose they need. So obtain an LDL within 48 hours of stroke onset. That's a Joint Commission measure for stroke centers. If your LDL is greater than 100, use high dose statin, one of the high intensity ones that we talked about. If your LDL is less than 100, you can use a lower dose statin only if you think that there is a risk, which in my practice environment, I haven't observed it. Keep in mind, there's a lot of patients that have aches and pains for all kinds of different things. And they say that when they were started on a statin, they have that, and so a statin is contraindicated. First, I explained to those individuals that aches and pains are better than death and disability. So, and then secondly, we want to have objective evidence that that's attributable to the statin. So you want to get a CK and follow that. And lastly is there's no class effect. So this actually happened to my dad. He was on atorvastatin and had his CK became like 4,000. So that was legitimate. It wasn't just a older guy who has aches and pains. Then they switched him to simvastatin, and for some period of time he was doing great, and then his CK went up to about 1900 or something. Took him off that. Now he's on rosuvastatin, doing fine. So you have to keep rotating these drugs in some patients until you find one that they can tolerate and there's no objective laboratory evidence that there's a contraindication. Just don't give up on statins and when the patient says, oh, I'm allergic to it, because unfortunately, you're not addressing their risk for stroke. Hypercoagulable state, I'm not going to read these all out for you. Usually most hospitals and Quest or LabCorp or Athena or whichever lab system you use has a checkbox, but this is what hypercoagulable state labs are. They do cost several $1,000s, so you need to be aware of that when you're ordering it. It's not something that you're just going to order randomly on patients. So secondary stroke prevention using antiplatelets, we have 3 different categories: aspirin, clopidogrel, and aspirin / dipyridamole extended release, also called Agrinox. There's also a couple of other ones here that I haven't listed, including Brilinta and another medicine in that same family. But the concept is that the dose of the aspirin is not well studied. What I suggest to patients, because everybody's always focused on cost, you go to the dollar store and you get the 325 milligram aspirin, you break it in half. So that's 162 milligrams, and each one of those bottles contains 200 tablets. So you can't tell me that there's a single patient that cannot afford $1 a year for aspirin to reduce their chance of a stroke. Then enteric coating NSAIDs may lessen their efficacy. I generally don't recommend prescribing the enteric coating unless you've sort of proven that you just can't tolerate it. Clopidogrel is very commonly used. Fortunately, now we have something called the P2Y12 test. It's a laboratory test that tells you whether the clopidogrel is working for that given patient. Now, the hard part of that is if your patient is non-compliant or semi-compliant, then you may make a poor decision by escalating them, for example, to Brilinta, which is extremely expensive in comparison to clopidogrel and has its own side effect profile that's a little bit different. So, but be aware that you can monitor the patient's efficacy of their clopidogrel, and then recognize that some PPIs can lessen the efficacy of clopidogrel. Aspirin dipyridamole, I've been prescribed this probably for about a decade. But once in a while, you see patients that come to the hospital and they're on it and they've not had a stroke since they've been on it, and they happen to be there for some other reason. In that scenario, I don't go and change somebody's medication, but this is something that it is FDA indicated. Stroke guidelines do support its use, but very few of us use it because of the headache complaint. Now, keep in mind, dipyridamole is an old, cheap drug, but the extended release only comes in this product. So and it's been shown that back when this product came out in the early 2000s, when patients or prescribers tried to just say, oh, we'll just prescribe cheap regular dipyridamole for you and have the patient take an aspirin from the dollar store, that does not work. That has been shown to not be efficacious. So there's something about this extended release formulation that has a completely different behavior for the patient. So do not ever give somebody regular dipyridamol with aspirin as a stroke treatment, stroke prevention treatment. The risk factor modification, we talked about cigarette smoking. You folks probably know more about this than even I do, because on the outpatient basis, these are common medications that you have to prescribe for people to try to, at least to some degree, get them to reduce their smoking. Lifestyle modification, alcohol for men, less than 2 ounces per day. Women, a little bit less, unfortunately for them. Diet, exercise, weight management. Here's the, if I could impart something on this group, I think we should, as a collective group of physicians, be much more conservative with prescribing estrogen-based therapies for people for postmenopausal symptoms or perimenopausal symptoms, hot flashes. We get, unfortunately, of course, we're biased. We only see the disasters. We only see the people who have a stroke. We get sometimes incredibly healthy people, people in better shape than I am, and they happen to be on estrogen for hot flashes and they have a stroke. Or that individual who doesn't want to use in that 35 to 45-year-old who doesn't want to use barrier methods of contraception. So I would really caution the use of oral contraceptives in anybody over the age of 35, and I certainly would not recommend its use personally, because we only see the disasters of stroke in the individuals that are 50, 60 years old. Sympathomimetics, obviously diet pills, the fen type products, which unfortunately have come back on the market, NSAIDs, if already taking aspirin, PPI in particular, omeprazole if you're taking Plavix. So here's some to summarize. So we want to prescribe antithrombotic agents based on cause. So anticoagulation if they have an intracardiac thrombus or if they have AFib, aspirin or clopidogrel for the majority of others, ARB or an ACE regardless of blood pressure. So here there's evidence that if you prescribe an ARB or an ACE for somebody without hypertension who had a stroke, think about that, that's a really small subset of people, that there's still some vascular remodeling benefit. So you might prescribe lisinopril 2.5 milligrams for somebody whose blood pressure is completely normal but had a stroke. And clearly that dose is not going to make them hypotensive, but there is some evidence that there is some benefit from doing that. Statin, regardless of cholesterol, here are your goals on the right side, obviously. A1C, blood pressure targets, LDL, we talked about, discontinuous estrogens, sympathomimetic drugs, cigarettes. Remember to treat carotid stenosis. Sleep apnea is a major contributor. There's hope that the pre-authorization of sleep studies is going to go away at some point, if it hasn't already. Sickle cell disease, you need transcranial Doppler ultrasound to monitor patients for stroke, because if their hemoglobin S fraction is greater than 30%, they have an extremely high risk of ischemic stroke, so they need a transfusion. And here's a picture of our beautiful downtown in Greenville, South Carolina. There's my email address should you have any questions. And again, I thank everybody for their attention and thank you for the opportunity to present. Are there any questions from the audience? Okay. Having heard none, I'll drop off. And again, you're welcome to send me an email. Here, ryan.hakimi@prismahealth.org. And I wish you a good last day of your conference. Good day.
You. So we have about 15 minutes and we'll get started with the next lecture.
Me okay?
Yes.
Hi, Dr. Bernard.
Hi, good morning. How are you?
I can't hear her. How do I hear her?
Uh-oh.
There we go.
Can you hear me now?
Yes, I can.
Okay, great. I just wanted to make sure that the microphone is coming through okay. I can move it a little closer to me. There we go. Is
No,
that better?
you're great. And we've made you co-host, so you should be able to share your screen with no problem.
Okay.
Thank you so much for agreeing to lecture for us. Dr. Kelly and I are actually really big fans. We're sitting here fangirling a little bit.
Thank you. I'm excited.
I gave your book out to 5 of our legislators this session.
Oh my gosh, thank you so much. That's amazing.
Yeah, and I'm the executive director. Audrey Hendricks is our director of CME who put all this together. So I know you've been communicating with her, but I just wanted to make sure I introduced myself because again, we're having a fangirl moment right here.
Thank you. Maybe one day I'll be able to actually come out in person.
We would love that. I mean, we might have to actually organize the fan club for that.
Yeah, we have
I would come out in a second. I have quite a few friends in Oklahoma as well, which would be always great to come out and visit.
yes. It's her.
Oh, one of our other board members
Another
is going to
fangirl?
come in and fangirl.
Aw.
Dr. Rebekah Bernard. She's the program director down in Lawton.
Mercedes.
And
Mercedes Bernard.
yes.
Another Bernard.
Hi, how are you?
I'm so excited to hear.
Thank
speak
you.
today.
I'm happy to be here. It's great to share this message. It's, kind of depressing, but we got to talk about it.
Yes, we do. We do. This is awesome. Dr. Kelly and I are fangirling really hard right now.
Thank you so much. And yeah, I would love to come out to Oklahoma someday. That would be so, so cool.
Hey, we will take you any conference we have. You are so welcome. We've got one in January at the Hard Rock, which is always fun up in Catoosa.
Listen, I mean, for real, let me know. I'm pretty flexible. And I have that new book coming out, The Imposter Doctors. It's coming out June 1st. So I would love to get the word out
wonderful.
about that.
It would be
Yeah.
amazing. And our legislative session here, as you know, runs through the spring. So we kind of get started in January. So that would be the perfect time to have you hype us up.
Rally the troops.
I would love it. Yes.
Awesome. Well, we'll be in touch then for sure after this.
Sounds good.
Bye.
Thank
Okay, we're gonna
you.
go with the next
Yeah,
room.
they're going to go listen to you, as will I. I'm going to get off of here, and I think you should be just about ready to go. We'll be here for tech support. We have our AV, so everything should be running smoothly.
Yeah, I'm just checking to make sure that I have everything. It looks like my talk is right here. So that should be pretty easy.
Excellent. Well, I am excited. Thank you again so much.
You're so welcome. I'll just unmute myself and turn off my video until it's time to go.
Okay, and I'll go into that room and make sure we're all ready. Thank
And
you
you'll
so
let me
much,
know.
Dr.
You'll
Bernard.
give me a cue when it's time to go. Yeah.
Okay, we will.
Okay. Thank you.
On the app, on the website, silent auction ends at 10 today. So if you were bidding on any of those items and it's close to time, make sure you get the last bid in so you can get it. And then we'll make sure that you get whichever item it is. If you're not here today, you can still get the item that you were working on so hard. Okay. And again, that all goes to scholarships for our medical students. So, okay. So our next speaker, you may know her, and yes, she's our keynote speaker, and it is on the last day. We're happy to have Rebekah Bernard, MD. She is a family physician and the author of 3 books, including Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. A sequel to Patients at Risk entitled Imposter Doctors will be released soon. Dr. Bernard received her medical degree from the University of Miami in 1999, completed her family medicine residency at Florida Hospital in Orlando in 2002, and has been self-employed in a direct primary care practice for the last 7 years in Gainesville, Florida. Please help me welcome Dr. Bernard.
Thank you so much for having me. I'm really excited to be here. It's an honor, and I just appreciate it so much. I'm here to talk with you today about advocating for physician-led care. Actually, let me make this the version that is, I think, yeah, ooh, I love it when technology works. So today we'll be talking about advocating for physician-led care. As you heard, I've written a few books. Patients at Risk was my exploration into this issue, and my new book, Imposter Doctors, gets into it a little bit more deeply because so much new information is evolving on this topic. So I'm going to start. I don't know why it just went forward, but apologies for that. This presentation is really factual and data driven, but I think it's important to put a face and a name to what we're talking about, because policy decisions are really, they have an impact on patients. So even though I don't like to just talk anecdotes, because someone can always say, well, I know a doctor that did something wrong. Of course, we know that's true, but it's still important to remember who we're talking about and why we're here. So I'd like to share with you a story of a young woman named Alexis Ochoa. Alexis was a 19-year-old college sophomore. She was on a basketball scholarship, and she was healthy. She had no medical problems. She did take birth control pills, and she had recently gone to a weekend visit back to see her family with her boyfriend. Upon her return to her dorm room, Alexis developed sudden chest pain, shortness of breath, and she fainted. Her boyfriend called 911, and an ambulance arrived and took her directly over to the emergency department. And when she got there, her vital signs were showing that she was unstable. Her heart rate was 140 and her oxygen saturation was 88%. Now, when you hear this story, I'm sure your mind is already jumping ahead and you're making your differential diagnosis. And right away, you're thinking this may be a pulmonary embolus. And in fact, the ambulance driver that took Alexis to the emergency room even said to the staff there, I think this young woman is having a PE. So the diagnosis was fairly clear. However, it wasn't quite clear to the person that received Alexis in the emergency department. Antoinette Thompson was a family nurse practitioner. She was working at her first job as a, quote, provider in the emergency room. She did have previous experience as an emergency room nurse and a firefighter, but she went to an online nurse practitioner school, as do about 50% of nurse practitioners now. And she graduated and did her 500 clinical hour requirement, providing prenatal care to low-risk women at a county health department. This is pretty typical for a lot of online or really any nurse practitioner programs. You can do your clinical hours pretty much wherever you find them. So this nurse practitioner didn't do her clinical experience in emergency departments, nor was her degree in emergency certification. It was as a family nurse practitioner. So when Antoinette saw Alexis, She didn't know what the diagnosis was. She ordered a number of tests, but one of the tests caught her eye, and that was a presumptive positive for methamphetamine in Alexis's urine. Now, Alexis denied using drugs. Her mom said she never touched drugs, and her boyfriend said she never used drugs. But when Nurse Thompson saw this result, she got sidelined. In fact, she had ordered some of the right tests to evaluate for a PE. She had ordered a CT scan, but she canceled it because when she saw that methamphetamine result, she just figured, I've got the diagnosis. This is methamphetamine toxicity. And over the course of 11 hours, Nurse Thompson continued to treat Alexis as if that were the diagnosis, giving her different medications to slow her heart rate, and basically giving her all sorts of futile treatments as the patient continued to decline. After about 11 hours of the patient declining, Antoinette finally transferred the patient to a tertiary center at Oklahoma. It's right there in Oklahoma where you are. And but unfortunately, shortly after, even though they made the correct diagnosis and started her on anticoagulation, Alexis died. Now, what's important to note is that this was not a rural, underserved emergency department. This wasn't a safety net. This was a hospital owned by Mercy Health Systems, which you there know of because it is a very large hospital administration service. They own hospitals and they own clinics, and they're worth about $6 billion. And because of a lawsuit that happened regarding this case, we have a lot of facts about the policies that were made by that organization, which were a strategic plan to replace physicians with nurse practitioners. And the organization decided to fill the role of physicians with nurse practitioners, including family nurse practitioners without training in emergency medicine. Not only did they do that, but they allowed these nurse practitioners to staff the emergency department and the hospital floors as well without any on-site physician supervision. And you have an example of what happened because of that decision-making. So what happened, of course, is that the family sued and Mercy had to pay a $6 million judgment. Unfortunately, the attorneys have told me that this didn't change their practices. They continued to hire nurse practitioners in this role. Something interesting that I learned, though, is that just shortly after the verdict was given, Mercy closed El Reno Hospital, citing a lack of enough, that they had to do renovations of the hospital and that there was not enough demand for hospital services. So what ended up happening to Antoinette Thompson? Well, she got a slap on the wrist from the Board of Nursing. She had to do some coursework. She had to pay a fine. I think it was $1,000. And then she moved right on over to Iowa, and she got a job in a Veterans Administration system in a hospital. And she works in the emergency department there, or she did last I checked. And what's interesting is that the Veterans Administration has independent practice for nurse practitioners across the country. So I don't know whether she's practicing with supervision or not, but I do know that she is allowed to, and she continues to practice. And the reason I share this story is not to point the finger at any one person, because this is just an example of what's happening across the country. And it's an example of what happens when hospital administrators and government entities make the decision to remove physicians as the leader of the healthcare team. So first of all, let's understand a little bit more about the differences in training, because we can't advocate unless we know. You all know what it takes to become a physician. We have standardized training thanks to the Flexner Report in 1910, which made it very clear that it is not okay to have an apprentice model to become a physician. It's not okay to have proprietary medical schools. We need standardization in order to safely provide care. So of course, we know that physicians will receive at least 11 years of training before we are allowed to be independent. Nurse practitioners have, I would say it's probably fair to say 5 years of training, But what's interesting is that there's some nuance here regarding how they can do their training. While physician training is standardized, nurse practitioners generally will have a 4-year Bachelor of Nursing degree, but not always. They can start with a registered nurse degree, and then they can enter into programs that are incorporate a bachelor's degree into a master's program. And they have accelerated programs that can speed them through. Then they also have part-time programs. So there's a lot of variability on how they can get their nurse practitioner degree. But typically there's a 4-year undergraduate nursing degree, although another caveat, about 20% of nurse practitioners now attend direct entry programs, which means that they can have a bachelor's degree in anything, art, theater, psychology, and then they enter directly into a master's level nurse practitioner program. So they get a nursing license and a nurse practitioner license right at the same time. So that's really important when you hear, well, no, nurse practitioners have to be nurses for decades before they can do this. That's not true. They may have been a nurse maybe for a short time, or they may have never worked as a nurse a day before they become a nurse practitioner. So we'll say that 5 years for a nurse practitioner to be certified, and keeping in mind that the hour requirements, as I mentioned with Antoinette Thompson, they are required to complete 500 hours of clinical training. Again, not necessarily standardized. Many programs require their students to find their own preceptors. So they're basically scrambling to find any willing body in many cases. That can be a physician or it can be a nurse practitioner with experience. So there isn't really standardization as far as who it should be done with or what setting. So remember that physicians complete during our 11 years, 15,000 hours of experience. And that's important because studies show, not just in medicine, but in any area where you need to gain expertise, that it takes about 10,000 hours of dedicated study to master any area of anything. If you want to be a chess player, if you want to be a tennis player, if you want to master piano, you're looking at least 10,000 hours. So physicians get 15,000, and you know that even when we graduate, we're still feeling like we need to know a lot more. So nurse practitioners, a minimum of 500 hours, and studies show that the average is about 686 hours. So a little bit more, but still quite low. Physician assistants, they have a 4-year undergraduate degree. Master's program is 2 years. And so they have about 2,000 clinical hours when they graduate. So despite these differences in our educational background, you can see here that nurse practitioners have unsupervised practice in now 23, that I know of, 23 states of the union, and working their way towards getting what they call full practice authority across the country, or the right to treat patients without any physician involvement. This photo is from their website. Oh, I'm hearing an audio click. Is there a question or concern? No? Okay. If you look at this picture, you see this is from the AANP, American Association of Nurse Practitioners. So you got to look at this as an opposite. They see green as good. Green means they can do whatever they like. Red is bad because they have limitations on their practice. Look at Oklahoma. I'm proud of you guys. Florida, my state, listed here in red, but really we're probably yellow because primary care is now allowed to have independent practice. So this is a map from 2019, so it may not be quite accurate right now, but you can see that there's extensive battles for nurse practitioners to be independent. And a new phenomenon is PA independence, or what they call optimal team practice. And I kind of get where they're coming from, because I'm sure they're thinking of this from an economic perspective. If nurse practitioners can practice independently, we have about 4 times the amount of clinical experience. Why can't we? And you'll see here that North Dakota became the first state in 2019 to pass independent practice. And they were followed by Montana, Utah, and then this year, Arizona granted independent practice. And you'll see how they phrased it here. They say Arizona becomes 4th state to remove the tether between PAs and physicians So always framing it in a way, instead of having patient safety, it's about they're being restricted and physicians are holding them down. So it's just an interesting way to look at the way that these issues are presented to legislators. So how did they do it? When you think about it really, you have to admire these groups, because how the heck do you take someone with a fraction of the training and experience and convince half the states in the country that you can do the same thing? And it boggles my mind, because I sometimes think like, it's almost gaslighting. You wonder like, now, wait a minute, why did I go to med school and do residency? I could have just done this online program and I'd be just as good. So the fact that they've gotten that argument accepted is really quite amazing. And we can learn from that, actually, because the number one thing they did was they worked together. And back in 1993, 137 different nurse practitioner organizations and nursing groups got together for a summit. And they decided that they were going to focus on one thing, and that was nurses being paid directly for services rather than billing under a physician. They made that their sole goal. That was all they were going to focus on. They put their differences aside and they got that done. And I often think how amazing it would be if we physicians took a lead from that and put our differences aside, how much we could get done. So with that cooperation, they focused on political advocacy, very clever. A lot of support from organizations like Robert Wood Johnson Foundation, which created these executive nurse fellowships. And they basically trained nurses to become political allies. They got them in these amazing positions. Like there was a nurse and a nurse practitioner who was on Bill Clinton's payment commission. There was one that was chief of staff for Bob Dole. I mean, there were a lot of things happening in the 1990s that were really carefully and strategically implemented, and we're seeing the results of them now. They also were very good about funding legislators to get their mission passed through. The other thing they're very good at is rebranding, which, you may have heard the expression, brain of a doctor, heart of a nurse. So, this idea that we're as good as doctors, but actually we're better because we care and we listen. Or look at PAs, they are now, of course, they're physician assistants, then they change their name to just say PA, and now we are physician associates. So this kind of constant effort at rebranding to try to show equivalency or try to make this argument that we're as good or better. And it's been strategic. They've spent millions and millions on marketing and on PR, and it's gained results. Here's just a few pictures of what you see when it comes to getting together and being politically savvy. I've spoken with doctors who were previously nurses and nurse practitioners, and they've told me that part of their curriculum in nursing school was political advocacy, that there would be certain days that the school would organize buses and all the students would get on the bus and they would go right on up to the Capitol in their scrubs or their white coats and their stethoscopes, and they would walk the halls. And you can see that that makes an impact. It really, just showing up in a presence like this is pretty meaningful. And that was very effective. So knowing this information, we need to figure out how we're going to advocate for including and keeping physicians as the leader of the healthcare team. And it's going to be important, first of all, to know the facts when you're speaking about it. Be prepared to clarify misconceptions, which in some cases are just outright lies. And so you need to know how to answer those when you hear them. And then I think it's just so important that we stay focused on why we're doing this and why we're here. And that's really patient care and patient safety. A lot of times when I'm talking about this or writing about it, I get a lot of hateful criticisms. And one of the most common ones that I hear, and I'm sure all doctors who talk about these issues do, you're arrogant, you're elitist, you're trying to keep other people down, you're not a team player. And those comments really hurt because they're not true. But they're not meant to strengthen the argument. They're meant to detract from the argument. They're meant to redirect us so that instead of staying focused, we're responding to these criticisms. So for me, a family doctor who grew up in a trailer, you're calling me elitist. And so I could answer that and say, here's why I'm not. But that doesn't matter. What matters is that patients are at risk, and we're doing this because we care about patients. The reason that I went to medical school and did that long residency wasn't because I wanted to be called doctor. It was because I wanted to make sure that patients got the proper care. So let's go and talk, let's focus on the facts. This is something that I did not know when I started working on the book, Patients at Risk. You know, you see all these headlines and you read these meta-analyses, and they sound really good. You'll see all these studies. Nurse practitioners were just as good at physicians at doing X or Y. And you start to think like, wow, well, maybe there's something to this. But then when you actually read the studies, what you discover is that every single study that's ever been done has always involved physician supervision. Every one of them, even when they claim that they don't, when you dig into them, you'll find out that they do. And further, every study always removes high-risk patients, and usually they focus on minor issues, low-risk issues, so they're very cherry-picked. Now, I do want to say that studies are very clear that nurse practitioners and physician assistants, when they're working under physician supervision, and when they're following certain protocols or algorithms, or they're managing low-risk situations, they do an amazing job. And studies show over and over again that when we work together, patients can get great care. However, there are no randomized controlled studies evaluating care provided by non-physicians without physician supervision and involving care of typical patients with typical problems. It's just not done. It's not out there. And I find it interesting because we've had unsupervised practice for decades in some of the states out west, and yet where is the data? There's been plenty of time to compile that information or to do a study, but it's just not there. And I think that's very telling. Of course, what you hear is there are 5 decades or 50 years of research demonstrating the excellent outcomes and high quality of care provided by NPs. That's the mantra, and you hear it all the time. And again, if you don't really dig into it, it sounds really good. For example, if you look at Cochrane, which we trust, right? Cochrane is objective. They're supposed to be unbiased. They're a large public organization, and they produced a study, a meta-analysis comparing nurses to primary care physicians. And what they concluded sounds pretty convincing. They wrote here that nurses probably provide equal or possibly even better quality of care compared to primary care doctors. Wow. When you hear that, again, I say, why did I go to school? I don't understand it because I'm obviously not that great despite all the work I did. Well, let's take a look at what Cochrane used to come up with that conclusion. First of all, they found 9,000 studies evaluating care of nurses acting in a primary care role. Of those 9,000 studies, just 18 had the quality that they could use to evaluate that met the criteria. And you'll see that of those, they weren't that great. In fact, just 3 of them were published in the United States. 100% of the studies involved physician supervision. Every single study excluded high-risk or complex patients. The studies were small. One of them, I think, had 69 patients in it. They were short. One study was 2 weeks long. The average length of follow-up was 14 months. And again, these were straightforward problems, known diagnoses. There were no studies that evaluated undifferentiated patients or new diagnoses. And yet, despite that, we are hearing the mantra that they can do the same thing. Well, maybe they can, but with certain very limited types of care. Now, the VA, as you know, has granted independent practice to nurse practitioners, and yet you can see here that the quality of evidence, which shows no difference, by the way, you see outcome, health status, quality of life, mortality, no difference. Okay, nurse practitioners can say, look, there's no difference between the care that we provide. Studies have shown it, but look at the strength of evidence. Insufficient, low, insufficient, low, insufficient. So you can take data and you can say it shows something, but what kind of data are we actually dealing with? And yet there is data to show some concerns about the quality of care. We have seen over the decades of research that nurse practitioners and PAs order more labs, they order more radiology, up to 400% more in imaging of chest x-rays and also CT scans, especially in the emergency room. They prescribe more medications, including opioids. They tend to be some of the highest prescribers of opioids. They prescribe more antipsychotics, including to children, which is a big concern for me, seeing this push to NPs in psychiatry. I'm really worried about that. That's a big trend I'm seeing right now. They prescribe more unnecessary antibiotics. Their referrals are poorer quality compared to physicians. They miss more skin cancers, but they do more biopsies unnecessarily. And overall, they actually end up being more expensive, even despite lower salaries. And you can find the citations to all of this at my website, patientsatrisk.com, so that you can check out these studies yourself. And then we have some newer data that's really interesting that just came out. This was actually one of the reasons why I felt that I needed to write a new book. Is one, I wanted to respond to some of the criticisms that I received from NP leaders, but two, because the data is just coming out fast and furious. So there was a need to add this information. And the Hattiesburg Clinic is a big one. Hattiesburg Clinic is in Mississippi. It's one of the largest accountable care organizations in the country. And they had a model where they allowed nurse practitioners and PAs to have their own patient panel. Now they assigned them less risky, lower risk, healthier patients. So they were taking care of the quote, easier patients. And the physicians had their panels. And technically the NPs and PAs were under supervision in the sense that they had a doctor right there. So if they had questions or concerns, they could go, but they were managing patients themselves. After Hattiesburg analyzed data from 33,000 Medicare patients, they found really interesting data, which was that physicians actually outperformed the NPs and PAs on almost all of the parameters and significantly when it came to vaccinations. Further, the non-physician practitioners had more referrals and ended up costing the organization more money, to the degree of $28.5 million annually. And this was important enough to the organization that they completely redesigned their structure. Now the NPs and PAs don't have their own panel. The physicians have a panel, and then physicians see patients first, and then they make a diagnosis and develop a treatment plan. Then the patient may be referred to the doctor's NP or PA for a follow-up visit. But anytime something new comes up, or at least once a year, the physician is seeing the patient. And it seems to me like that is really what the original model of NPs and PAs were created for. And it's really interesting to see that coming back full circle based on data. There's also some interesting economic data coming out of the VA. This was a quasi-experimental analysis that was performed by David Chan with Stanford. And what they looked at were the independent nurse practitioners working in VA emergency rooms. And they discovered that these nurse practitioners used more resources, especially ordering CT scans. They had poorer patient outcomes, and that overall, they actually increased healthcare costs, even considering that they were making about half the salary of a physician. Some of the other information that's coming out is support from our allies, which are our nursing colleagues. And there were several studies produced by nurse researchers. Lavin and Venema, they are a duo that are actually nurse practitioners, but they focus on research. And they are very concerned about this increase of use of nurses in emergency departments, especially when they're not certified, like Antoinette Thompson, they're primary care certified. And they went and reviewed and found that very few, a significant, only just the smallest minority of emergency nurse practitioners working in that setting have emergency certification. Most of them are family primary care nurses. It would be like having me as a family doctor working in an emergency room, seeing patients by myself. Maybe I could do some of that, but it's definitely not going to be the same as getting an emergency physician. And then even the ones that have emergency certification, it's the amount of education and training is really substandard, not standardized at all. And so that's all laid out in an article that was produced by these researchers that concluded that NPs should not be providing independent practice in emergency rooms, even if state law says so, because it's dangerous. Another group of nurse researchers looked at family nurse practitioners. This is the most common type of nurse practitioner. And they were really concerned with what they saw, which was that students are reporting negligible experience in foundational primary care. Many of them reported that they had only had 3 to 6 experiences with learning how to take a history, learning how to do a physical exam. There were a pretty good chunk of students that reported never using or prescribing a medication one time during their training. And these are people that are graduating and then being, in some states, allowed to practice independently from day one. And so this study produced a big concern about the educational quality. So we have some facts behind us, and now we need to be prepared to clarify some of the misinformation that's being given out there. So one thing that I want to talk about is this false equivalency. And now you have some facts. So when you hear, well, studies show that NPs are just as good or better than physicians, you can say, well, they are if they are under supervision and they're managing low-risk situations. Yes, but otherwise, no. But what I think is so interesting is some of the propaganda that we're seeing out there to try to claim equivalence. The CRNAs, they are really taking this to the mat. And this picture from them just shocks me. You see here that what they've done is they're comparing CRNA education to anesthesiologist education. So they've given themselves 4 years of credit for their undergraduate nursing degree, but for physicians, our undergraduate college degree gets negative years. We don't get credit for that. And then they've also counted a doctorate degree, even though most CRNAs don't have a doctorate, and whether doctorates in these fields really adds anything clinically, probably not. 15%, only 15% of DNP, doctorate of nursing practice degrees are clinical. In other words, they're mostly about writing studies or doing political advocacy or computers, things like that. But yet they included that here. So they try to show this equivalency to say to legislators, look, we have the exact same training as an anesthesiologist. So I just think this is amazing. The other argument that you hear, and legislators really like this, is that they're told that NPs or PAs, if they get independent practice, that they are going to fill the gap, that they are going to increase access to patient care. Especially, they're always promising that they're going to do more rural care, underserved, and primary care. Unfortunately, that's not accurate. It's not true. It hasn't panned out. But before we even get into that, let's talk about access. Does it really matter if I have access to someone if they don't have the skills and the training to take care of me? Well, I would think no, but more importantly, there are data that show that more patients die worldwide due to poor quality care than die due to lack of access to care. And this is kind of crazy. When I came across this study from the Lancet from 2018, it really kind of blew my mind, because what it was doing was looking at developing countries like in Africa, and they found that when you take a person that has a little bit of training, but not a whole lot, and you put them in these rural areas without access, and patients go to see them, patients are getting the wrong diagnoses, they're getting the wrong treatment, and they're getting delay in proper diagnosis, and they're dying. And actually, what the study recommended, this was sponsored by Harvard, the study recommended to stop this strategy of trying to put all these little clinics all across these rural areas. And instead, they say it's better to actually go ahead and transfer patients, get a bus, or help them get to the tertiary centers in the cities where they have standardized proper training. Even though it's not easy from an access standpoint, this is actually saving lives. So we need to really rethink this whole idea of, do we need to have necessarily people in all these rural areas, or do we just need to have a better way of people getting to the right place where people have the right training? So really interesting, something to think about. But anyways, NPs aren't going to rural areas, and really neither are PAs. States that have independent practice and have for a long time have not seen the promised mass entry of NPs to practice in these areas. It's just not happening. And in fact, a study in 2012 tried to incentivize NPs to work in these areas. The government spent $179 million on a pilot project, and after 5 years, just 9% of their graduates went into rural areas, 25% total went to underserved, and just 12% went into primary care. So it's just not happening even when there are incentives. So we can counter some of those myths, and then really what we need to be doing most of all is just redirecting to patient care. You've heard some of the concerns about safety and quality and cost, but then there are other issues that we need to think about. One is transparency. Do patients know who's taking care of them? In the case of Alexis Ochoa, the nurse practitioner introduced herself as the attending physician. And it wasn't until after her death that the family even learned that she was cared for by a nurse practitioner. And I'm hearing these stories all the time where there's not proper identification and patients just don't know, or they make an assumption, but they may be wrong. And when things do go wrong, sometimes there's not justice because nurse practitioners and PAs are not always held to the same standard as physicians in malpractice cases. And then also, there are some pretty big concerns about whether boards of nursing are properly overseeing some of the practices that are out there. So patients do deserve to know who's taking care of them. I just don't think that you can really argue with this when you talk to legislators or really anyone to say, yeah, patients should have the right to choose. The nurse practitioners had a PR campaign called We Choose NPs. That's great. I say if patients want to have a nurse practitioner managing their care, that's their choice. But they should know who that person is and what their training is. Right now, there are 183 different nursing certifications, and you'll see that with what I call alphabet soup after people's name, a list of letters. And who knows what that really means? I tell people, ironically, sometimes the least number of letters is the most, credentialed person that you're going to be seeing. So patients don't always know what that means. We know that the doctorate degree has entitled some nurses and PAs, they have a doctorate of medical science now, to call themselves doctor. And they're supposed to add, their doctor of nursing at the end, but that's not always clear. We're also seeing the ologist, like nurse anesthesiologist. We're seeing terms like board certified and residency and fellowship, and it doesn't mean the same thing when it's a nurse practitioner compared to when it's a physician. So patients kind of need to understand that better. And I will say that some states are making efforts. I'm not sure what Oklahoma is at with this right now, but Indiana and New Jersey have really led the way in advocating for mandating truth and transparency. And I was really happy because I just saw that Florida just passed, hopefully the governor will sign, just passed legislation to require that there be more transparency in medical titles and to remove this appropriation of physician terminology. Regarding justice for malpractice, it's really interesting because you'll hear that, nurse practitioners are responsible for the care that they provide and there's no difference. But you can see here from case law that juries are often instructed that they cannot hold an NP or PA to the standard of a physician. And it becomes an issue for plaintiffs' attorneys because they can't present a physician as an expert witness against an NP. They have to present another NP. So some plaintiffs' attorneys, like in the Alexis Ochoa case, they made the argument to the judge that the standard of care should be the care that a patient expects to receive in an emergency room, for example. Not that it's an NP, but it's an emergency room, quote, provider, as much as I hate that term. And that's been successful, although it takes a lot of work for attorneys to make that argument. And so some of them, when they see it's an NP or a PA, it may not be worth the effort for them to take those cases. We also know that malpractice claims for NPs and PAs are often tied to physicians. So in many cases, the NP or PA will be dropped. And of course, the lawyer will seek damages against the physician who may be the deeper pocket. Now, this is starting to change, not only pushing this different standard of care for a setting versus the actual clinician, but back in a few years ago, the North Carolina Supreme Court ruled that a nurse, a CRNA, could be held responsible for harm caused to a child during anesthesia, even though they were technically under direction of a physician. And that challenge to the court may open the door for more challenges. But as of right now, if you're harmed by an NP or a PA, you may not be able to really seek damages for that. And then oversight is a problem. And the reason, I think, is because these boards of nursing are responsible for a lot of people. You know, they're responsible for overseeing LPNs, RNs, and APRNs, and it's a lot. And what we're seeing is there are cases across the US where they're just not capable of doing it. Out in California, the Board of Nursing got in trouble because it turned out that they were lying and hiding documents because they wanted to make it look as if they were staying on top of things when they weren't. And it's really just, there's just too much work for them and they couldn't keep up. So we just don't have enough resources of the boards of nursing. And also the question, of course, is on these boards of nursing, they have a few nurse practitioners, but a lot of them are LPNs or RNs. How do they determine whether or not someone without a training that they've done is following a standard of care? So what can we do to help fight and advocate for physician-led care? You know, before I talk about the getting involved, I think we need to just take it back to our own personal ethical views of practicing medicine. And this is something that I've been thinking a lot about recently. You know, there's this idea of beneficence in medicine, you know, doing good for patients, and non-maleficence, not harming patients, and then patient autonomy. And those are the three really pillars of medical ethics. And whenever you do something, you're supposed to be thinking about, is this helping the patient? Is this not harming the patient? And is this what the patient wants? And when it comes to non-maleficence, I start thinking, you know, if I'm complicit with working with someone that I know isn't providing the right quality of care, even if I have to do it for my job, for example, I'm required, let's say, to supervise, you know, doesn't that put me in a real moral quandary? And I think that it really contributes to this idea that we hear about from Wendy Dean and Simon Talbot about moral injury. And I think it really does, it is something that's tough for us. So we really should think about whether contributing to a system that is removing physicians from the leadership of care, whether that's something that we can ethically participate in. And that may mean some hard decisions for a lot of us because we may work in systems where it's required. In some cases, we may not have a lot of options, but I would encourage you just to think about it. If you are supervising an NP or a PA, that's great. And just, are you doing it the best that you can? Is your company allowing you the time to do it properly? And just holding ourselves responsible, because, you know, physicians are complicit in some of this. You know, the NP and the PA profession was created by physicians. The idea was to see more patients and to do a better job of patient care. And of course, it's gotten away from us, but I don't know that it would have if we had maybe pushed back more, maybe not. But I guess the point is just that there are always going to be some physicians that are going to, either they don't understand the situation, or maybe there's some financial gain involved. But I think we just need to look at ourselves very hard and make sure that we are holding ourselves to the highest standard as far as medical professionalism. So beyond that, getting involved is really the key. You're doing it now, you're here. I'm preaching to the choir because you're already participating in your medical society. So I always encourage everyone to join your groups. Remember how I said the NPs really were successful because they worked together. And a lot of times I'll hear, well, I don't want to join that group because I don't like how they do this, or I don't like that. And I get it. Believe me, I've dropped different groups because of different personal issues that I've had. But more and more as I move through my career, I see and realize the importance of solidarity and unity and working together. PACs is just so evil, isn't it, that we have to put money into getting our mission or getting our point of view across. Even, money doesn't necessarily mean you're going to get what you want. It just means you're going to get your foot in the door to talk with someone and make your case. And it's, again, one of those things that it hurts my heart, but I serve on the PAC board of my Florida Medical Association, and I kind of hate it, but I also recognize that it's part of the way the world works, and that we have to make those allies and friends in the legislature in order for them to hear our perspective. Please educate your colleagues once you know this information, and don't be afraid. I know it's scary to speak out, but couching it in those terms of, I care about patients. This is nothing bad against any group of people or persons. This is just simply a concern that I have, and we need to talk about it. And educate your patients. When I send a patient to a specialist and I see that they only gotten seen by an NP or a PA, I get pretty upset about it. I don't mind if they're involved in the care, but I want my patients to be seen by specialists. And when they go to the ER, I want an ER doctor involved in that patient's care. And so I try to talk to my patients about that and let them know what my expectation is and how important it is that they are treated by a physician. Ultimately, the most important thing is that we're all patients. And if we're not patients now, we're going to be patients. I guarantee it. One day we're going to be that person on the gurney looking up. And the question is, are we going to be looking up at a physician who we know did the same training we did? Or are we going to be looking up at someone that maybe just graduated from an online program who has no experience, and they have no one to ask for help because there's no one else there with them? And that's because, we sat quietly and let this continue. So, and if you don't think that could happen, I'll point out one last thing, which is that right now there are about 1 million practicing physicians in the US. And many of us want to get out of medicine, unfortunately, because of the way it is. And physicians are graduating and leaving residency at a growth rate of 3% per year. And I don't see that increasing unless some big changes happen to residency funding. NPs, there are now 390,000, I believe, NPs. Their growth rate is about 30 to 40%. And for PAs, there are about, I think, 200,000. Their growth rate is less, about 20%. So you see where I'm going with this. 1 million physicians, many trying to get out of practice and only growing at 3%, of rapidly growing NP and PA pool with no sign of slowing that growth. That statistically, there's a chance that there may be less physicians than non-physicians one day. So this is something that I think is going to become more of an issue unless the pendulum starts to swing, which is what we're here to do. To learn more about this topic, I would really encourage you to consider joining a group that I've been involved with called Physicians for Patient Protection. Our website is here, and we really are solely focused on one thing, which is advocating for physician-led care and truth and transparency among healthcare practitioners. So please consider joining our group. Of course, I would love for you to get my book that I co-authored with Naran Alajba. It's called Patients at Risk. And then my new book is released on June 1st. It's called Imposter Doctors, and it builds on Patients at Risk. And so I hope that you'll read that and like that as well. And now I think that I've got time. If you're set up to take questions, I've got time to do that. And I really thank you for letting me speak. I'm going to look in the Q&A. Maybe I can see it. No, I don't see any questions in the Q&A. And I'll just wait for a few moments to see if anyone has questions there.
Can you hear me, Dr. Bernard?
Yes, I can hear you.
Okay.
Can you hear me, Dr. Bernard?
Yes, I can.
Okay, so I don't see any questions online, but we do have some people in the audience today. Do we have any questions of the audience? Okay, I see one from Dr. Jeanette Kelly on our board. Yes, Dr. Kelly.
I guess one thing that a lot of physicians are stating as an issue is they can't see enough patients because of the way they are reimbursed from the federal government. And is there anything being done now so that that can be changed?
Yeah, you're 100% right. And that is the reason, one of the main reasons that I now do direct primary care, because I think that doctors are now put in this assembly line model where in order to just pay your overhead, because hello, inflation, and yet Medicare just cut physician pay, and insurance companies do everything they can to pay us as little as possible and to give us a runaround. I think that that is why, one of the reasons why physicians have turned to physician extenders to help them see more patients. It's totally understandable and, you know, done well, or as well as can be done, as example in a Hattiesburg clinic model. That makes perfect sense. For me, I had to get out of that assembly line model. It just wasn't good for my mental health. So I did it for many years, and now I do direct primary care. As far as whether there's any government will to change that, I'm not seeing it. I mean, you've seen what just happened this year with Medicare. The AMA was very vocal about the damage that it was going to cause. I'm kind of personally at a point where I feel like at some point doctors just have to say, no, we're not doing this. It's not good for patients. It's not safe, and it's not fair. And I feel like that's the only way that something might change is by walking away. I know that's hard because we care about our patients. We want to be there for them. So that's an excellent question. Thank you. And I don't have an answer to that, and I don't really see one, unfortunately.
So, that was very loud. I'm sorry. So in our chat, Dr. Knox said, thank you for the insightful perspective. And Dr. Sheila Newcomb said, your presentation was excellent and needs to be shared with every lawmaker. Thank you for your voice. And then Dr. Lovelace has asked a question. Have you seen any studies looking at PAs who did ER fellowships after obtaining their degree? Are they safer?
Such a great question. The NP and PA quote residencies and quote fellowships, I call them, because y'all know out there, if you applied for a fellowship, you were probably the creme de la creme of physicians, and you worked your butt off to get there, and then you worked really hard during your fellowship. Whereas and I think the NP and PA fellowships and residencies are somewhat competitive because there's not a ton of them, but we're talking about like 40-hour work weeks, weekends off, you know, clock out at 5. And I think they make about like twice as much as a physician resident or fellow, which is funny, not funny. So the question is there data? And that is very limited. First of all, there are no overseeing bodies or accrediting organizations that oversee NP or PA residencies. So we don't really know what the standards are. It's basically an institution that decides that this is what they think is important and how they want to train someone. And then as far as actually seeing hard data on those programs, I'm sure that there probably is some starting to come out, but I haven't seen anything large. Of course, you would think someone gets more training and more education, they're going to be better, they're going to know more. One of the things that throws a kind of a snafu in this is that when you're training all these NPs and PAs to do these roles, what happens to the training of the actual residents? And what we're hearing now from medical students, residents, and fellows is that they're actually having to compete with non-physician practitioners for procedures and for training opportunities. And the first study that has ever been published on this just came out like within days, 3 days ago. It was a study of emergency medicine residents, and 69% of them said that having NPs and PAs in their facility has adversely affected their education, and they had a 14 times decrease chance to do procedures. So there could be some good things about these residency type programs, but also keeping in mind that maybe that's going to detract from physician education.
Thank you so much. And we have another question online. Can you talk about what the Facebook PPP group is? Is that the patient protection group that was mentioned?
Yeah, so Physicians for Patient Protection is an organization. You can find us on our website, and there is a Facebook group. It's not really an official group. It's more of anybody that's a physician that wants to talk about these issues can be in the Facebook group, and it's venting and talking and sharing these stories. And actually, this is how I learned about how serious this problem was. I worked with a few NPs and PAs and had some questions in my mind, but I thought it was maybe just me. And then when I was on this Facebook group, I started seeing all these posts from other physicians saying, this is really scary. This happened to me. And someone else saying, I saw it too. And it's so funny to see doctors saying, I went to my doctor and I was given a PA or an NP. And when I asked to see a physician, I was told no. And so these are the kind of stories that we hear. And this is what got my mind going on this topic. So yeah, if you're a physician and you'd like to join the group, you can join through our website. And then if you're on Facebook and you've friend me or one of the other doctors that you know that's in the group, then you can be added to the Facebook group too, if you're interested.
Do you have any more questions in person? Anybody? Okay, well, thank you so much to Dr. Bernard. We were so thrilled to have you. I hope we can, my goal is now to get you here in person. I think you've got quite a growing fan club here at the OOA, and we really appreciate all of your work on this and the excellent resource you provide to us as advocates for your profession.
Thank you so much. I really appreciate it.
I will now stop hogging Dr. Stone's microphone.
We will give it a few minutes and get started back at 10.
Testing, testing my video and my audio.
Right, I am too. I'm gonna pull, do you want me to pull up our slides real quick too? I'll just go ahead and do that. Does everything look okay? Okay. Right.
Our next two presenters are from the Oklahoma Child and Adolescent Psychiatry and Mental Health Access Program, Dr. Tessa Chesher and Dr. Rebekah Lee Hubbard. Tessa Chesher, DO, is a clinical professor of psychiatry and behavioral sciences at the Oklahoma State University School of Community Medicine. After her child and adolescent psychiatry training, she completed a Harris Fellowship in Infant and Early Childhood Psychiatry at Tulane School of Medicine. She is an endorsed infant mental health mentor, clinical and research faculty. She is the lead of OSU's Infant Mental Health Extension for Community Healthcare, ECHO. She serves as a medical director for the Oklahoma Child and Adolescent Psychiatry and Mental Health Access Program. Rebekah Hubbard, PhD, is a research scientist and adjunct assistant clinical professor at Oklahoma State University Center for Health Sciences in the Department of Psychiatry and Behavioral Sciences. She holds a PhD in human science and an MS in professional counseling. She is a licensed professional counselor candidate and a certified family life educator. Please welcome Dr. Chesher and Dr. Hubbard.
Thank you so much for having us this Sunday morning. Rebekah and I, or Dr. Hubbard and I, are very excited to talk with you about a program that we have here in Oklahoma that's been around for a few months, but we've actually been laying the groundwork for over about 1.5 years now. So we're going to talk with you today about the Oklahoma Child and Adolescent Psychiatry and Mental Health Access Program, which is a mouthful. And so we would prefer to just call it OKCAPMAP. All right, so I think I'm going to state the obvious here that guess what? We have mental health needs in Oklahoma, and children are especially vulnerable to these mental health needs. So everybody on this call knows this. And so the need is, how do we increase access to mental health services? And the other need would be, how do we prevent some of these things that's going on, which is probably one of the things that can actually start turning the tide even more. But when we look at Oklahoma, we're not doing so hot. We have numbers. They're not very quick in giving us kind of updated numbers. And so our numbers are going back to 2021, where we ranked 46th for youth with a high prevalence of mental illness in the nation. So 46 out of 50, and 33rd for access to care. So we are in a severe shortage area in the nation for child and adolescent psychiatrists, with an average of 7 child and adolescent psychiatrists per 100,000 children. Now, I look at this map, and if you look at the map, you can see kind of the area of child psychiatry needs throughout the nation. And most of the nation is in a high shortage, severe shortage area, except for maybe like the DC area. And then I will go and I'll look at the people. I'm like, okay, who are the child and adolescent psychiatrists in Oklahoma? And I'll look at the list. And many of the people on the list are either retired, not practicing anymore. And so when we say 7 per 100,000, I think that that is a high estimate for what we actually have here in Oklahoma. In addition, our suicide rate is much higher than other parts of the nation, and it only is increasing over time. And I have a very strong feeling that it's going to be increasing even more with all of the things happening recently. We're kind of setting the stage for that. So we've increased our suicide rate 103% since 2007. And when you look at the national rate, it's increased by about 42%. Now, this is, again, 2021 numbers, and we are not doing well now, and I expect it to increase. Suicide is still the second leading cause of death for ages 10 to 24. We also all know that Oklahoma is a very rural state. compared to the nation. We're not like the most rural by any means, but we have many rural areas in Oklahoma. Poverty is a known social determinant of both physical and mental health. And we know that in our rural areas, we have high amounts of poverty. We also have high amounts in our urban areas too. But you can see the comparison there to the rest of the nation. I'm going to hand it to Rebekah to go over some more data. And I'm going to hand the baton to you. We're going to go back and forth today.
Thank you, Dr. Chesher. So just to go a little more granularly with that data from 2021, the Youth Behavior Risk Survey showed us that 43% of youth in Oklahoma felt sad or hopeless on most days in the last 2 weeks when assessed. 23% were having active suicidal ideation at that time, and 18% had a plan. We also had 10% that attempted and 3% that attempted ending in an injury or death. These are very important to understand because this shows the continuum of where we can step in, right? We all know that hopelessness is the #1 factor correlated with suicide ideation. And then as you can see, some of those that are hopeless are experiencing that ideation, moving to a plan, moving to attempt it. So we have many points along the way that we can intervene. And we hope to show you one of those points today with OKCAPMAP. Next slide, please. So this is the average monthly number of visits by youth for mental health needs in the ER under 18 years old across the United States. And as you can see, this is a graph just depicting that these data points we're already sharing with you in the ER setting. And we are very excited that not only are we able to provide our program to primary care settings, but we have additionally extended to EDs, and we'll talk a little bit throughout the program about that. But as you can see, there's been quite a jump from 2020 up to 2022 with a total of 2,666 under 18. Thank you. So who should start this conversation, right? We talked about that continuum and where along the way can we intervene and step in and offer some support and services to keep kiddos from going into a place of suicidal ideation or complex diagnoses, et cetera. And that is in the systems, right? So medical, health, school-based, families. And as you can see here, when initiating conversation about mental health, when asked parents, who would you like to initiate the conversation about your child's mental health? They showed clearly that they prefer the doctor. And second, of course, is the parent. So clearly they're showing that they see a partnership between the doctor and the parent, because the third is also doctor or parent. The partnership between the two to really address a child's mental health. Some of them don't feel comfortable or maybe don't even understand what mental health is, so they don't bring it up. So it's very important for doctors, especially primary care doctors who are seeing their patients on a regular basis for well child checks, to be able to bring up that topic and engage with family around their child's mental health.
Thank you, Rebekah. And I'd like to thank also Dr. Coffey and Dr. Erdman for letting us pilfer their slides too from their presentation they recently gave at our conference. All right, so we're talking today about child psychiatry access programs, and we've called ours OKCAPMAP, and we'll get into this because there are lots of names for the same thing, just to make everything confusing. So I want to go over the history here a little bit because I think it's important to kind of set the stage of what our mission is, what our goal is. So the need for child psychiatry and child mental health services is not new. It's not like it just came up around COVID. We've had this for a long time now, decades now. In the early 2000s, the Surgeon General came out with a report that said, hey, access to child psychiatry is extremely hard. Like we have a need for child psychiatrists. We have an increase in mental health needs in the kids, and they can't get to who they need to see. And that was in 2000, and we're still saying the same things now. So at that time, they were also talking about an increase in prevalence of child mental health issues. And so people started thinking, what do we need to do about this? And Massachusetts, who often has a lot of the new ideas, said, you know what, we are going to try to have just like a phone-a-doc line, like a doc to doc. Let's have a child psychiatrist answer a phone, and primary care providers can call and say, hey, I have a question about this kiddo. Can you help me out? And so the University of Massachusetts is the one who spearheaded this pilot program in 2003. And by 2004, the whole state, through the Department of Mental Health and the Massachusetts Behavioral Health Partnership, said, hey, this is something I think we need for the whole state. This seems to be a viable solution to really get services by specialty trained. And we just heard about how important that is, that we need highly trained individuals to provide these services. And so this is a way that we can expand that. And so in 2004, the Department of Mental Health gave money to the state to expand to the state. And then other states caught on, and they're like, yeah, that seems good. And several of them got together and they started talking about what was working for them, what was not working for them. And they started sharing ideas. And this grassroots program grassroots group came around, called the NNCPAP, which is also an acronym for a very long title of the National Network of Child Psychiatry Access Programs. And so they just started as this informal group, really trying to band together to provide child psychiatry services. In the beginning, it was Child Psychiatry Access Programs, or CPAPs. And then in 2014, the NNCPAP was officially incorporated as its own official group, and it spread across the nation, which is great. And why did it spread? It spread because even though we don't have a ton of data, we're getting a lot more. And this is some of the first data that we did have. So what they found was that states who have child psychiatry access programs, the old name for what we're doing, the primary care doctor said, hey, I'm more confident in providing mental health care for my patients. It is important to provide this mental health care. We know that primary care docs are the first line of defense in identification and treatment of mental health disorders. And they also found that children residing in states who had CPAPs were more likely to receive mental health services than children in states without CPAPs. So that seems obvious, but I think we need to see data a lot of times. And guess what? It's true. I think you may have heard that I did an infant mental health fellowship and infant psychiatry fellowship. And so the little kids are at my heart. We have about 500,000 children in this nation on psychotropic medications. And when we break that down, it gets really scary. So when we're talking like about 1,500 kids under the age of 1 on benzos. Where Adderall is probably, the number one a medication prescribed in ages 0 to 5, and methylphenidate, but there are plenty of others. And the increase of the antipsychotics is scary as well. And so what we saw in one study, it said, hey, in our state that did CPAP programs, there was a decrease in psychotropic use in young Medicaid kids. And so we're giving tools to primary care doctors to say, this is the evidence base. We're treating kids with, fill in the blank, a preschooler with depression. We know meds don't really work that well, but we do know other things can help. And so really teaching those things. And so we can do that through the phone line. We also showed a reduction in unnecessary hospitalizations, which also makes sense. If you can call a line and say, here are the symptoms, here's what I'm seeing, we can say, monitor this, weekly, do X, Y, and Z, here's, suicide assessment, whatever. Or, yeah, they need to go to urgent care now, and you have somebody by your side telling you that and helping you through that. then you can probably see a reduction in unnecessary hospitalizations, but part of that's also due to an increase in screening. All right, so then the federal government started noticing these programs grow, and they said, yeah, we have a huge mental health need. And so HRSA came on board, the Health Resources and Services Administration, and said, yeah, we think this is a great program. We're going to start funding states to have pilot programs in their states to grow these services because they seem to be working well. And it's at this point that we see a name change, so don't be confused, as the Pediatric Mental Health Access Program. So instead of CPAP, which focused on child psychiatry, we don't just need child psychiatrists. We need a lot of children's mental health providers. And so I didn't do anything. HRSA expanded that to include mental health providers as well. And so we have CPAPs and PMHCAs. And you can see this is a map of who they funded. And so the blue states are the ones who already have these programs. The teal on my screen, that was the first group that got funded. So those states are the first HRSA group supported by the federal government. And then we have green here, that's the 2021 funding. So, we're going to have to change this map because there is 2022 funding as well. So this really isn't accurate. There are more states and territories that received funding. In case you don't know where we are here. It is morning on a Sunday. But here we are. We were in the 2021 state funded group. So we're very excited about receiving funding to start a child psychiatry access program. I tend to call them CPAPs because that's when I learned about them, was about 6 years ago. So that's still on my brain. But if I say that, I do mean the PMHCAs. And so we had a lot of partners who were interested in having a PMHCA in Oklahoma. And so they helped us write for this grant. And so we're very thankful to our partners. But the grant goes through a state entity. It has to go through a state entity. And so it goes from HRSA to the Oklahoma Department of Mental Health and Substance Abuse Services, and then to OSU, which is where Dr. Hubbard and I are. And then it goes down from there. And so kind of complicated funding, but we'll talk in a little bit as well about expanded funding that we've received and some braided funding because this has grown a great deal and we're really excited about that. But we also need sustainability. So we've been working on that as well. And so in a nutshell, what we do is to provider support for primary care, pediatric behavioral health care. And so really helping pediatric primary care providers who treat ages 0 to 21. So that's also important to know. People define pediatrics differently. HRSA defines it as 0 to 21. So providing help for the primary care providers. And many of the CPAPs and PMHCAs all of them have really unique programs. So it's really exciting to see kind of the differences on where they focus their efforts on. Dr. Hubbard and I decided to start with the basics. And we kind of really wanted to go back to the heart of the CPAP programs and then grow from there, because we both feel strongly that building a strong foundation is important as we grow this, because we have great ideas to grow and expand as well, but that won't happen if we don't have a good foundation. And so you see here the 3 parts that we started with. So we started with the mental health consultation you see on the right there. That's our phone line that we're going to talk about all three of these more along the way, referral assistance and mental health education. So we're going to talk about each of those 3 pieces. All right, so Rebekah, I'm going to hand the mic back to you.
At first, we're going to talk about that foundation that Dr. Chesher was referring to. When we sat down, we were awarded, we were very excited, but we said, okay, let's see first what providers' needs are, and let's develop an advisory board. So we developed an advisory board of wonderful partners across the state. And we divided them into different work groups to focus. Neither one of us are really interested, as probably most of you, in meetings that are not productive. So we are very focused on working together with these entities across the state. And those work groups, I want to share with you what they're divided into. And as we share the program, I want you to know that we are very inclusive. And if you have a passion and an interest in this type of program and you would like to have a voice in the advisory board, please do. Our contact information is at the end of this. Please do reach out. We would love to talk to you and see how we can partner with you and collaborate and either bring you on with the advisory board or in another advisory manner or support your work. We're open to any kind of conversation around collaboration. So those work groups are sustainability, as mentioned by Dr. Chesher. This is seed funding from HRSA, and we've been grateful and thankful to receive some additional private grants from foundations. And but it is seed funding, and we need sustainability. So we have some great partners at the table around that. We have some excellent partners around the table on provider recruitment and engagement. So your OOA is represented, OSMA, both the boards, OAFP, OAAP. So we have many of the all the medical boards and associations that are related to primary care on our advisory board, helping us to recruit and engage. So when you get those emails from them, please open them up and you'll get more information about OKCAPMAP. We also have a education and training, which Dr. Chesher will share more and more about later on. They're doing an excellent job building out some robust education around mental health. And then we have a mental health referral network, which I will talk about later, which is a comprehensive referral support database for our referral assistance through OKCAPMAP. And then our final one is systems navigation, because we all know that it is quite challenging to navigate the mental health system. And we want to put information and training, provide training to providers so that they can wrap around those families and support them in the navigation of the system. So with the provider needs assessment, we partnered with our data manager, Dr. Michael Hartwell, to create a simple provider needs assessment to send out and say, what do you need for pediatric mental health? And most of these data points probably won't surprise you, but it's always good to have it in black and white. They were sent out by the boards and the association. So shout out to all of our partners there. This was very early on. We sent it from December to May in our first year, which was the year. It's okay. You can go ahead to the next one. We sent it to December to May, which was early on. We used our first year to build the foundation, and you'll see why in a second.
I got excited there, Rebekah.
I know. I finally got you excited about data. No, just teasing. So we had a little over 200 providers, primary care providers respond, which we were ecstatic about. I'm married to a primary care provider. I know what his life is like every day at the office. So the fact that we even got 50 made me thrilled. And so we had a little over 200. And as you can see, the breakdown here between allopathic and osteopathic, excuse me, providers. We were also surprised to get some registered nurses and a couple of physician assistants, even though that wasn't our target audience. We were happy to have their input as well. Then our participants, next slide, please.
And I'm going to throw this in here and interrupt. The allopathic numbers and the osteopathic numbers, I would like to say, just shout out since we're at the OOA conference here, that the percentage of osteopathic providers in the state, I wish I could, some of you guys might know offhand, but it's a lot less than 27.7%. And so meaning by per capita, our osteopathic physicians responded at a higher rate. So kudos to us. So thank you guys.
Yes, special love to all the osteopathic physicians out there. And then participants by specialty, as you can see, and not surprising, pediatrics was our largest responding population, followed by family medicine and then internal medicine. As you can see, we had 34 other, and we were quite curious about this. So there were some ones we really weren't surprised by: general psychiatry. I can't remember the other, but the one that we were surprised by, but then we stopped and said, you know what, that does make sense, is we had a plastic surgeon respond. And we are very grateful because we are always grateful for any providers that are thinking about mental health in their physical care of medical health. Next slide, please. So this slide right here by Dr. Micah Hartwell is the reason that we took a year to build our foundation, because we originally planned in our grant proposal, we planned to pilot launch to Tulsa our first year and kind of figure out all the nuances and steps and pieces and adjustments and adaptations that needed to be made, and then move to the rural eastern side of the state our second year, and then go to Oklahoma City our third and build there, and then our fourth go to the rural western side, and then our fifth, we'd be full statewide and complete in our services across the state. However, when we got our data back and Dr. Hartwell took this data and put it into this scattergram across, or scatter plot is what you would technically call it, across a map of Oklahoma, as you can see, we have a really beautiful splatter, which means to us, as you can see, 46.8% rural representation of respondents to our survey, which says to us, rural providers are desperate. They need support and they need help around mental health, and particularly pediatric mental health. And even those circles that are around, those larger circles of Tulsa and Oklahoma City, those near metro, and they may be non-metro or rural, they are also struggling and need support. I wouldn't say struggling, they need support. They're asking for support and we want to provide that. So we took a year to build that foundation, to really talk with our advisory board, to really build out the infrastructure for what we're getting ready to show you that we launched at the beginning of October 2022. Next slide, please. These are the questions that we asked the providers, and I think this is interesting. I think we'll come back around to this on a regular basis and kind of see, because you'll see in the next couple of slides when we move forward that I did some qualitative interviews as well. And as I did those qualitative interviews, one of the things that's not in the slides is that I found quite a number of providers that didn't know quite what we meant by consultation, or didn't quite know what we meant by education. Referral assistance is kind of a no-brainer, right? So, okay, you're going to help me refer out. But even that, we needed to provide some clarification, because the goal is to bridge the gap by using child and adolescent psychiatry as partners with the primary care or emergency room providers to meet the pediatric need in that primary care setting or that ED setting, versus referring out to a child and adolescent psychiatrist to make that diagnosis. So as you can see, we had about 89% said, yes, absolutely, we could use support with referral assistance, approximately 80% with consultation, 30% for education for staff, and 45% for education for provider. Next slide, please. So as mentioned, we said, hey, how many of you 210 providers would like to do a face-to-face interview? And to our surprise, 108 responded, yeah, I'll talk to you. So we were very excited for that collaborative disposition of those providers. Unfortunately, we were, at the time we got that data, we had just a couple of months to get ready to launch. So I had to provide just short windows that 20 primary care providers were able to block some time in and do some interviews with me, and we gleaned some points of interest. I'm excited to go back to those other 90 providers that said, yeah, I'll meet face-to-face and talk to them. Have you registered? How's it going? If you haven't, why not? What are your needs now? But for now, we've got these 20 primary care provider qualitative interview themes. So they said, we need medication consultation beyond the initial evaluation. Maybe I can do a Vanderbilt and diagnose ADHD, but what if it might be something more? Or what if medication is not working? What do we do next, right? Alongside with that too, developmental and complex diagnoses, education and support came forward. In other words, okay, it might be ADHD, but I think there might be some anxiety as well. Or maybe there's autism and I think there's anxiety. Those complex diagnoses where we're not quite sure what's going on, or maybe we have multiple or dual diagnoses. and developmental disabilities, challenges around those areas and how they present, and diagnostics around that, as well as if they're presenting with the IDD as well as a mental health disorder, what is the best approach with medications and education and support services for that child and their family. Again, they emphasize their referral assistance to mental health services and supports. And they also pointed out something that we've known for quite some time: medication management with post-discharge care. Unfortunately, sometimes many pediatric patients come back to the primary care setting with medications that primary care providers are not comfortable with prescribing, and they don't know where to start to adjust or to continue or what to do. And so we're there to help with that. And we're excited that that was a need. We don't want people to have a need. Sounds terrible every time we say they have a need, but we don't want them to have a need, but the fact that they have the need and we're able to meet that, we're very excited about. So of course, being the good therapist that I am, if you had a magic wand question, I asked them this: what would you put in your clinic today? And of course, they said in-house psychiatrist, counselor, and case manager, which is exactly not in-house, but we're providing at the tip of your finger in calling us and accessing our support services. Next slide, please. A couple of challenges also came forward, most of them not surprising either. And I really am grateful for these challenges coming forward. I am a big, if we've got a barrier to mental health care for kiddos, how do we remove it? How do we go over it, or how do we go around it, right? And so these challenges come forward and tell us what those barriers are and how can we help to address that from our little space that we have with OKCAPMAP. So one, access. Rural areas have limited internet access for telehealth and teletherapy. We know this. What we didn't know is that some rural areas also have very limited cellular coverage. So even if we wanted to do teletherapy using cellular coverage around Idabel and outskirts of Idabel, you can't do that. It's not accessible. I was told that many providers don't even in that area don't even carry a phone once they leave because it doesn't work. That was anecdotal, so don't hold me to that. It wasn't my words, but someone did share that. So we started kind of noodling around, where can we provide supports? You know, if we make a recommendation and they hit a barrier, how do we help them to go beyond that barrier? As we know, this goes hand in hand, which I just talked about, is services are very limited in rural areas. And so we go to teletherapy or telehealth to try to use that as a solution, but right, we might hit another barrier. Parental understanding of mental health needs can be a barrier. The providers shared their frustrations and concerns and hopes that we can provide some parental education and empowerment and motivational interviewing skills around the parent. And then complex cases needing that higher level of intervention that's not currently available. We send quite a number of kids outside of the state or simply don't have them in the services that they need. But however, again, OKCAPMAP can be an answer on catching these needs early and addressing them earlier on so that they don't become complex and they don't have to go to inpatient and they can stay in their home with their family and garner health and maintain that health. Next slide, please. I think it goes back to you.
Yep, and we are back to this slide to really, we said we're going to go deeper into each of the three parts, so that's what we're going to do now. And we've talked a lot about consultation, and so basically we have a phone line where it is available Monday through Friday, 9 to 5. We are not a 24-hour crisis line. We are the people that you call when you have the kiddo in your office and you're like, hey, I've tried all these antidepressants, or I've tried, I'm questioning this diagnosis. I don't know exactly what it is, or I have these side effects to this medication. At what point do I switch? Or I'm trying to switch between two, but I don't know how to cross taper, something like that. I've had all of those questions. You can call the line. And when you call, we have a licensed professional counselor who has over 15 years of experience in various parts of the mental health field, including working with primary care. and she will answer the phone. So Christina Brent answers the phone, and we do get basic information, but not patient information in the specific sense. So for example, we'll have ask age ranges, not ages, because we are not, we are basically HIPAA compliant, but we are also de-identified. And so we're de-identified to a point. If you do give us information, because as people talk, they tend to say some stuff, we're not going to write it in your recommendations or anything like that. But we will, when we talk about the patient, or when we document as far as specific documentation, it's okay, this child's age is 0 to 3, or, whatever their, this demographic, male, female, other, we have the general information. So we've had to balance what information we ask for and this de-identification quite a bit. So we work with the IRB on, okay, what can we ask? What can we not ask, as we're kind of tread this balance here. We do have an EHR that, as I said, it is HIPAA compliant. We use Salesforce and collect data in, because if you call back, you also don't want to repeat everything. And we want to have the chart, be able to open this chart. And so we identify it based on your medical record number that you have for the patient and your initials. And so, if I had, Dr. Wheeler call me and say, I have this patient, I would say, okay, this patient, and what's your medical record number? And she says 1234, then it would be KW1234. So her initial is 1234. And then when she calls back, which I'm sure she'd want to, then we can pull it up by that de-identified information. All right, so a lot of the questions, we've had some simple questions all the way to extremely complicated questions, like a lot of our kiddos have. We know that Oklahoma is really high on the trauma scale. And so trauma has many lookalikes, and a lot of times we'll get the call of it's ADHD. Well, it's, probably trauma based on the story that was given and based on the symptoms. And so we can help delineate that. And sometimes it'll take several calls, and that's okay. We can give you next steps to do and break it down with you. So you're not feeling as if, oh, I got to do all this at once. We can break it down into steps, because that's what I do. So why wouldn't you do that? And so we can help walk you through that. So I said 9 to 5, Monday through Friday. We are available. Look, I went too fast. We are available to pediatric primary care providers in outpatient clinics. I mean, really, we don't have huge, mostly outpatient clinics have called. We've had one ER call as well, and we are open to that as long as, it's 9 to 5, Monday through Friday. We don't take over the care of the patient. This is totally doc to doc. And not me taking the patient. Because if I took the patient, I fill up in a week, and I'll have a waiting list that is, forever long. And so that's not the goal here. The goal is to help empower you to provide the care and walk alongside you so that we can treat more kids. There was something else I was saying, it flew out of my head, but I'm sure it'll come back in a minute. So we will move on to the next one. We have a lot of partners, as Rebekah said, and one of the things that we've also partnered with in the groups is OKA's Oklahoma Pediatric Psychotropic Medication Resource Guide, which I like to joke that Dr. Coffey made that name way too long. But we really use this resource guide in a lot of our recommendations. We really want to be consistent with what we're saying. And this resource guide was created with best practices at that time. So I know we need to update some of it because it is a couple of years old. We need to reduce some lit searches, make sure we don't have more information to add in there. But this is basically a cookbook, if you will, where you could go in and you can say, hey, here's pediatric depression. If it's age 3, then that would be the infant mental health part. And you'd see that I wrote like stage 1, stage 2, stage 3, stage 4, kind of what broke it down into the parts and pieces that you might think about. Or trauma, you have a 17-year-old with trauma, what are some of the things that we want to think about with trauma? And I like it because it gives you kind of guidance as well. So that is, those are one of our many partners. And I also forgot to say we have 3 child psychiatrists currently that man the line. Actually, the correct thing would be women the line because we're all female. So there's me, there's Dr. Sarah Coffey, there's Dr. Swapna Deshpande, and then we have one more coming in about a month or 2, hopefully, and then another one coming at the end of July. We've broken up the full-time job into like little parts and pieces, so there'll be 5 of us, which will be amazing, and then we hopefully will expand from there. All right. So currently we have, well, I'll get to that in a little bit. These are our current numbers of how many people we have registered. So across Oklahoma, we have 296 providers registered. It's free. All of this is free. This is a resource to help providers. 196 consultations have been done on 101 patients. So you can see that people are calling back about kiddos. And this is 500 people have gone to education. Honestly, I think it's probably more, but that is our guess because it's hard to tell how many people read some of the educational materials. Oh, I know what I was going to say. So when you do consultation, we are trying, one of the things we're working on is sustainability is getting the code open so that when you call us, that you can use the billing code, the CPT code for our consultation. And so we've been working with, you name it, we've probably been working with them, to be honest, and really also working with the potential Medicaid providers as well. So we will see when they come to say, hey, we need this code open so that when primary care docs call us, they can bill it and have some reimbursement for your time. Probably not as much as you spent and deserve and all of that, but I think it's a start to get our foot in the door to grow that. All right, our second part is our resource referral network. I'm going to pass that to Rebekah.
Thank you. Thank you, Dr. Chesher. So, and Dr. Chesher will walk you through at the end on how to access the line and the hours and all of that and what it kind of looks like, just so you know. So hang on for a second. We're going to give you the how-to at the end. So this is the one part of our consultation process is a referral assistance, as mentioned, right? So the idea is to really create this network of recovery around the child and their family in their location so that their recovery is sustained and they're not circling back around to more complex diagnoses or challenges or the ED or inpatient stays, right? So we really want to try to give those best fit connections and give resources and information to parents to really empower, educate, equip, and empower them to be advocates and supports to their children. And then also to really strengthen that continuity of care, right? From the PCP to the family to the mental health provider and back around again. Next slide, please. So we decided to create something called the Oklahoma Mental Health Network. It is housed under OKCAPMAP, but we needed to kind of be able to talk about it as a piece of it, if you will. And that mental health network is a comprehensive database that we are building out to adequately, appropriately, and comprehensively have resources available at our fingertips to share with providers, to share with families. And those resources can include mental health services, they can include family services, they can include resources, information, materials, and they can include what we call supplementary materials, which I'll get to here in a second. Next slide, please. I'm going to go kind of quick because I think we're getting a little short on time, and I think we might have some questions too. So the mental health network is divided into referral practices and referral providers. We have these seven. For some reason I was thinking it was six. No, 6. Sunday morning, guys. Okay, 6. areas that we are gathering information, and we have a wonderful project assistant that is working very diligently for gathering information on outpatient, inpatient, and crisis response mental health services across the state of Oklahoma, as well as adjunctive situations we often see like developmental disabilities and domestic violence, and of course, family services, which with that, we're talking about social determinants of health. You know, is there a need for food support? Is there a need for housing support? Is there a need for divorce care? Any kind of situation that might be occurring in a family that puts added stress and pressure on that family and on that child that's already experiencing a mental health disorder. How can we come alongside and alleviate some of that with some structure and supports in their area? What we found over many years is that people simply don't know. We have these amazing supports and services out there, and families don't know they're there. So this is the idea of really helping bridge that gap, utilizing the primary care and emergency room providers to provide that information to the family and the child so that they can then create that network. And then the referral providers, specifically outpatient, but we imagine we might have a handful of developmental disability specialists and family service specialists that we want to get granular data on. So I'll take outpatient as an example. We will be sending out surveys to all licensed psychologists, clinical social workers, licensed professional counselors, licensed marriage and family therapists, and licensed alcohol and drug counselors. And I believe I hit them all. If I didn't and you're in that category, please forgive me. We're sending out granular surveys. And what we're doing is we're looking at kind of what is the expertise, right? So out of these 30 diagnoses, what 7 do you have the most experience with? Out of these 8 age ranges, what 3 do you have the most experience with? Out of these 7 special populations, African American, Native American, LGBTQ+, et cetera, what 3 or 2 or 3 do you have the most experience with? Because the idea is really to be able to say, okay, these are the needs of the child and the family, and these are the providers that can best meet those needs, or has the highest level of expertise, I should say, can meet those needs. And then giving them that list, that kind of honed and focused list to try to work with and connect with and create that network of recovery. Next slide, please. So on our website, we do have a website, by the way. It is OKCAPMAP.org. If you Google that, it should pull us up, or an article about us that you can then link to us. On that, and Dr. Chesher put it in the chat for those of you that are online. On that website, we have our provider education page, which Dr. Chesher is going to tell you much about that, and registration, of course. And it's very simple. Registration is super quick. You do need your NPI number, so that's probably the hardest part. Please do enter a phone number and an email, so when you consult with us, we can get back to you in an expedient way. But it also has provider resources and family resources. And this is a screenshot of the provider resources. And as you can see here, it has several areas, and we'll continue to revise these. We really started initially with just threw up what we knew off the top of our head, right? And that's what's there because, as mentioned, we launched in October. We've been quite busy. So we hope to revamp this in the next 6 months, adding more and more information and continually. You have your general, each green block has a drop down. You have your general, your screening, medications, which has the psychotropic pediatric Oklahoma, I think I can do it, Oklahoma Pediatric Psychotropic Medication Guide, I think. Underneath it as well, to link to it, as well as that QR code will take you there in our slides, and then some professional organizations. We will continue to expand this out, but this will be your provider resource page, and we are adding screenings and additional information as we go. Next slide, please. This is an example of family resources. We have our local resources in the first block. Particularly interested if you know of something in Chakota, Oklahoma, or Altus, Oklahoma, or Willard, Oklahoma, anywhere, right? You let us know, and we will add that there underneath that location so that that's available to families. Then we have our statewide resources and then national resources that we will continue to add to as well. Next slide, please. And this is an example of some supplementary material that we're working on. We mentioned continuity of care and parent empowerment, and really enveloping that family, that parent around that child with support that helps educate, equip, and empower them to be their child's best advocate. So we are doing what to expect rack cards. So just little rack cards are about half of a page in size, a standard page in size. And on the front, you're going to see what to expect from. And that, right, as you can see the example here, National Alliance on Mental Illness. We have one on Oklahoma Family Network, which is an excellent resource, especially for developmental disabilities and mental health disorders. On the backside, I'm a mom of a good number of kids, let me put it that way. And so I know that as a mom, a busy parent, we are not going to read it if it is in prose. If it is a long, lengthy thing, we might read the first couple of sentences, but we're busy. Something happens and we're distracted. So I'm trying to make sure that we are down to 7 bullet points or less on everyone, which means where I was going to do one about wraparound services in the mental health system, I had to break it down to be a general wraparound, and then we'll go in detail with with family support providers and care coordinators. Same thing with psychological evaluations, 504s, IEPs, et cetera. So these rack cards will be available to our registered providers without charge, and we are excited to support them in that manner as well. I believe next slide is back to you for our awesome education.
Thank you, Rebekah.
All
All right.
awesome because it's her mainly.
Yeah.
She's parents.
We have the pediatric mental health education pieces as well. So that includes quite a few things. The first thing I have on here is specialty training, and we are going to expand that in the coming months and years. So hopefully we will have some specific training that we can come to your office and do. So that will that's to be determined, not even to be determined. It's coming soon. The asynchronous online modules are kind of our biggest unique thing, I would say. So we have online modules that you can go and go through the OSU or OK State CME website, and you can, if you're a registered provider, you will get a code, and that makes these all free. And so 1 hour of CME, like we just put one out a couple of weeks ago on substance use in adolescents, and it counts for, the training hours that we need for our 8 hours. And so you can go and do that, and you also get 1 hour CME credit. And again, it's free if you're a registered provider. You just have to put in the code. This is an example of what the anxiety, the first page looks like, but we go over, just basics like symptoms, rating scales. I embed the rating scales so you can print them off if you'd like, or go to the website. We go through kind of the how to diagnose, but also how to treat. So what is step 1 in treatment, step 2, step 3 support, so on and so forth. And what are resources as well. So you go through each of that. I also go through a pretend office visit on each of them. And that is to teach certain things. A lot of motivational interviewing skills, or, we talk about empathic listening, or, some of the things that can be helpful in forming an alliance with your patient, maybe confidentiality, or, something like, all of them are a little bit different as to what we include. And so right now we have anxiety. Obviously, this is the anxiety, depression, ADHD, trauma, substance use, autism's next. We have opioids that will be after that. Cannabis will be after that. And then I have a list to continue with these. So I hope that you guys try them. Please give me feedback. I would love to hear. The other thing we do is lunch and learns. And so this first year, we'll have done 8 lunch and learns when it's all said and done. And these are kind of fun because we go on site somewhere. Most of the time it's somewhere rural, because we want to go to rural practices. If you want us to come to you, please let us know, because we need some rural locations to go to. We'll get lunch, and I like walking through a case together. So I'll ask questions about the case, and we'll walk through a pretend case together. And I'll insert the teaching things along the way. And that's worth 1 hour of CME as well. So you can see our upcoming ones, autism is May 17th. They're usually on the third Wednesday, not always true, but usually third Wednesday. This one will be at Just Kids Pediatrics at Florence Park, and I think I got that name right. And it'll also be on Zoom. All of these are on Zoom as well. And you can just join those for free. Our website, our provider education page has all the stuff coming up. I also want to throw this in there. I know a lot of us are osteopathic physicians, and I really think our program really looks at the body, the person as a unit, and we include that family in that unit. I think of what we do really embodies the whole individual. You're not going to call and we're just going to say, here's some medication. It's not the way I think about things. It's probably not the way you think about things. It's not the way we were trained to think about things. And so we might give you medication recommendations. Of course, I mean, that's my thing. I know how to do that. But I also know how to do a lot of other things. And so we know medication is just a potential piece of the puzzle. So we give you individualized suggestions that include more of these puzzle pieces that we know can actually further somebody down the road, whether it's therapy, whether it's the things Rebekah was talking about, housing resources, domestic violence resources for the family, things like that. Now, some of those take time. And so when we're talking, we may look stuff up offline when you're not on the phone and send it to you, but we send suggestions. We legally can't say recommendations, but we send you suggestions and we attach resources that could be helpful as well. All right, so logistics. I know we're running out of time here. As I said, Monday through Friday. I'm sorry, it says launches. It launched October 1st of 2022. It's free. We're not trying to sell you anything, but we just want to build this mental health team. Actually, we're selling it for free though. Please come join us. So you enroll online. You go to our website, you'll see a register. I say enroll, but it's really, we call it registration. So you'll see that button. You can call us. There's also an online way to put in a referral request that you can see on there, and you have to pick a time. Don't forget to pick the time. Otherwise it defaults to midnight, and I'm not calling you at midnight. So 9 to 5, Monday through Friday. We get together. You give us the story. We give you the suggestions. That's it. That's basically it. Here's our information. You can register at OKCAPMAP.org. And you're welcome to contact either of us with questions. All right, thank you, Rebekah, for putting that provider enrollment in the chat. And it looks like, I know we have 2 minutes here. And the question and answer, Sabrina and Dr. Schrader, thank you so much for saying our website's beautiful. Thank you. We would love for you to share at your residency in Oklahoma City. We'd love to come to you. If you guys want to do a lunch and learn there or host it, we would love to do that as well. Dr. Wheeler, I apologize for pulling you into this lecture, but thank you for letting me. And also thank you for your comments. This question is adjacently related to your presentation, but I was curious if you know of any programs that would incentivize physicians to specialize in child and adolescent psychiatry to increase the number of available clinicians to address these needs. Signed, my twin right there. All right, so no, what they're doing is not, well, I take that back. I think they're trying to do some loan repayment, expand it, because in the past they haven't included psychiatrists in that. I think they're trying to include psychiatrists, as you and I both know, that wasn't a thing when we were training. The other thing is they're trying to look at the training and say, okay, are there other routes to it? So they've created like the pediatric portal program where pediatricians can go and get a fellowship in child psychiatry. They also have to do adult psychiatry, which I think is a hindrance too, but that's one thing. And they're looking at decreasing the years in child psychiatry, which as someone who did 6 years of residency and fellowship and then an additional 2 years, I don't know how I feel about that, but there is discussion on that. Actually, I do know how I feel, but it's not, we have a disagreement in that training because we need people trained as well. So I know we're out of time. And I thank you for your questions. Feel free to email us with any more questions, and thank you for having us.
Thank you. Any questions in the room here for them? Okay. Thank you, Dr. Chesher and Dr. Hubbard. We really appreciate you being here for an excellent lecture. And let's give it a few minutes and then we'll get started with our last lecture.
Hi, this is Keli Hawthorne. I'm being asked just to test my mic, make sure that everybody can hear me. And I think we'll get started shortly.
Okay, let's begin our final lecture. We have Keli Hawthorne, MS, RD. She's a registered dietitian and the Director for Clinical Research for the Department of Pediatrics at the Dell Medical School at the University of Texas at Austin. Keli is also the co-director of the Dell Med School Culinary Medicine Program, which teaches residents and fellows about healthy cooking techniques and nutrition in order for them to personally increase their own knowledge as well as apply these skills when speaking to future patients. She is brought to you by the Oklahoma Beef Council. Keli's research background focuses on neonatal and pediatric nutrition, including mineral absorption, intestinal failure, and human milk fortification for premature infants. She was honored with a Texas Distinguished Scientist Award from the Texas Academy of Nutrition and Dietetics, and is a past recipient of the Emerging Dietetic Leader Award and recognized Young Dietitian of the Year. When Keli is not in Austin, she can be found at her cattle ranch in Shonk Mountain, Texas. Welcome, Keli.
Thank you so much. And thank you for the Oklahoma Osteopathic Association for sponsoring us today. This is a wonderful program. I had the pleasure of listening in on the mental health program right before this and was so excited to hear about all the wonderful resources that are available. So it looks like I'm closing us out for this little bit of morning session for you on your schedule, talking about nutritional needs. And I'm excited to be able to give you this information and really talk about some practical strategies that you can help talk with families about and make sure that we're meeting nutritional needs for our youngest patients, especially around 6 months of age to 2 years of age. All right, moving forward. Oh, it's supposed to advance. This worked fine before, pardon me. Oh dear. Well, my disclosures are that as mentioned, the Oklahoma Beef Council is sponsoring me today. I got connected with the Beef Councils early on when we were doing iron and beef absorption studies. And so that's how I've been associated with them. Let's make sure that, okay, now it's working. All right. So today's objectives, we'll go through and talk about some of those critical needs that infants have, particularly looking at iron and zinc. That's been the focus of my research for the past 20 years, and looking at some of those evidence-based guidelines, particularly looking at what the Dietary Guidelines for Americans have to say. And then again, we'll touch on some really practical nutrition advice that you can talk with your parents and families about. So the Dietary Guidelines for Americans, our most recent set were the 2020 guidelines. This, if you're not familiar with the Dietary Guidelines for Americans, by law, it is mandated to come out every 5 years. It's an expert panel of physicians, pediatricians, epidemiologists, PhDs in nutrition, registered dietitians, everyone who might have an impact in creating the best possible guidelines that we can have. The exciting thing about the 2020 guidelines was this was the first time ever to include children under 2 years of age. And so for those of us who work in this population, we were more than thrilled, you can imagine, to finally have some national recognition of nutrition impact and recommendations for this age range. In particular, the Dietary Guidelines for Americans are often used to develop policies for programs like WIC, for school lunch programs, for all kinds of federal, national, and state nutrition programs. And so really they are very critical to helping provide important information to drive these programs that impact so many of our families. And their slogan for the 2020 panel was make every bite count. They're already picking and have chosen the panelists to be on the 2025 dietary guidelines. And I've seen online that they're opening up for public comments. So if you have any issues of concern that you want to make sure that the committee is addressing, please go ahead and find that online, and you'll be able to submit comments and make sure that your concerns are addressed in the dietary guidelines moving forward for 2025. So we'll go back to some recommendations about starting solids in this age range. The American Academy of Pediatrics recommends to introduce solid foods around 6 months of age. They're particularly a little bit vague to give individual pediatricians options with individual patients. So it's not as strict as just exactly 6 months of age. But it's important to expose the baby to a wide variety of healthy foods and textures. They also say that there's really no medical evidence that introducing solid foods in any particular order has any advantage. specifically saying that there's actually no science that shows that you need to introduce vegetables before you introduce fruits. Otherwise, your baby will get a sweet tooth and they'll never learn to eat vegetables and they'll just be addicted to sweets. There's absolutely no scientific and medical evidence that supports that. The AAP also recommends that meats can be offered as an early complementary food at 6 months of age. And so we'll talk about that in the United States, that meat is typically not introduced until much later on, and what a beneficial source of iron and zinc that food source is. The World Health Organization and PAHO, the Pan American Health Organizations, they really do have an introduction at 6 months of age guideline. This is to do a little bit more with promotion of breastfeeding in developing countries where a water source to prepare infant formula may not be safe. And so their emphasis on breastfeeding is what drives this 6 months of age marker. They also recommend that meat, poultry, fish, or eggs should be eaten daily or as often as possible. And they specifically call out that vegetarian diets cannot meet nutritional needs at this age unless nutrient supplements or fortified products are used. And sometimes these are not as available again in developing countries. And so there's a little bit more of an emphasis on a non-vegetarian diet. Also, so then what do the dietary guidelines for Americans say about starting solids? They also say to start about 6 months of age and focus on nutrient-dense, developmentally appropriate foods. They recognize, as we all do, some infants might be showing signs of developmental readiness before 6 months of age, but starting solids before 4 months of age is really not recommended, nor is waiting after 6 months of age until they're 7 and 8 months old. And of course, we all know what those developmental readiness signals are. And so talking with families about that is important too. It's important to introduce allergenic foods along with other complementary foods, right? Starting at 6 months of age. And I'll spend quite a bit of time in the second half of the talk talking about introducing allergenic foods and what specifically those are and best strategies on doing that. But we have a reality check. Over half of infants start solids before the recommended 6 months of age. Now, granted, like I said, some of those around in that 5 months of age range may be developmentally appropriate to do that. But we do know, you can see in the blue section here, about 15% are actually starting solids before 4 months of age. We also know from NHANES surveys that this is typically happening in our Hispanic populations, our lower income populations, and our WIC families. So something to be cautious of in your patient populations. Why do parents do this? The most common reason is that they're adding rice cereal to a bottle to fill up their tummy so that they sleep longer. This is what advice from grandmas are often quoted among the families that we talk to. Every parent at this point is sleep deprived, and so they are looking for that. But I will say that it's actually inconsistent evidence. So there's some reports that that show a benefit, some that definitely don't, but it's definitely still not recommended by any organizations when it talks about starting solids. So why not do that? Well, before 6 months of age, it's really not appropriate because they do have a higher risk of choking because they are actually not developmentally ready yet. There's some long-term studies showing that starting solids, such as the rice cereal before 6 months of age, may lead to an increased risk of obesity. But also they may not getting enough of the right nutrients because you're now displacing some of the human milk or formula with the supplementary food, with the complementary food, and they may not be getting all of their nutrient needs that they need. And what about starting too late? Those that are more cautious or needing to, for some reason, they're delaying, they're not ready to do that yet, they're anxious. What we see with that, starting around that 7 or 8 month range, is slower growth, including in particular brain growth. We'll talk about the importance of iron for brain development. Iron deficiencies, delays in oral motor function. This can cause an aversion to solid foods and textures, so it becomes even harder to get the child to accept different foods. And then the postponing of allergenic foods actually does increase the risk of those items. The FIT study is called the Feeding Infants and Toddlers Study, and it's had 3 different iterations over the past decades. And the most recent data we have is from 2016. But this is really one of the most excellent resources we have of what are children in the United States eating? And this is a difficult age range to assess. Often it's just, little bites of this and that's how they eat throughout the day. And so it can be challenging, but this is really the best database that we have. So here we've got in blue bars are 6 to 8 month olds. In red, we've got 9 to 11 month olds. And in green bars is 12 to 15 month olds. And you can see here, this is the percent of infants eating this food item at least once a day. So infant cereal starts off pretty high and declines over time. That's normal and expected. It's declining because other foods are increasing. As you can see, the opposite situation with the meat and protein group, you can see that increases over time as infant cereal is declining. Fruits and vegetables are really pretty good. Actually, most kids are getting a fruit and a vegetable on a pretty regular daily basis. So we're pretty excited about that. But what you can see here too is that meat is typically not introduced until 9 months of age, even though all of the national and international recommendations encourage starting meat at 6 months of age. So it's really something that's not being translated through our pediatrician offices and our physician offices to families and parents to encourage them to do that. Another item and food group that we do see here, though, is dessert and sweetened beverages. And it's rather unfortunate, but by 1 year of age, about 75% of kids are eating a dessert or a sugar sweetened beverage on a daily basis. And so, again, that's something for us to be aware of and talk with our families about, that 1 year olds do not need to have sweetened beverages. They don't need to be having high C and other sweetened beverages, soft drinks, or desserts on a daily basis. That starting even at 1 year of age is the time to start developing. All foods can fit, but doesn't mean they need to fit in every day, and to have some things for special occasions. When we break down that protein group, you can see here that, again, we've got our same age groups listed, but baby food meat, like the commercial jarred baby food, that's the pureed baby food meat, is not very popular. Parents don't typically buy that. Reports indicate that most parents think it's pretty disgusting. They wouldn't want to eat it, and so why would their baby want to eat it? So it's a very low utilized resource. But now you could, what's more acceptable is encouraging families to make pureed baby food products at home when it comes to the meat products as well. Like they're making pureed green beans, they're making pureed carrots. You can make pureed ground beef as well. And so beef comes up a little bit by 1 year of age, but really again, at 1 year of age, the top 2 proteins that children are eating are chicken nuggets and hot dogs. And so again, it's something for us to consider about if that is what the best that the family can do based on their financial situation. Well, we're glad that they're having a protein source. If there's an opportunity to make some improvements, then that's a great place to start with your families and talking about what are some other quality proteins that they can be including. So I'll go throughout the talk and list some of these dietary guideline recommendations. I put them in quotes, so I'm pulling out the exact quote that is in the report, and then I've highlighted in bold in different areas what I'm going to emphasize and what I think is important for today's talk. So one of their recommendations is that for infants fed human milk, it is particularly important to include complementary foods that are rich in iron and zinc when starting complementary foods. So again, if that's about 6 months of age, then it's important to have that iron and zinc source, especially for human milk fed babies. And we'll talk more about that. Why is it important to start to have that resource at 6 months of age? Well, it's because babies, as we know, they're born with especially iron and zinc stores in the liver. And so, but by 6 months of age, these stores are pretty much utilized already. So this is an important time to start introducing a nutritional source of iron and zinc because they no longer have those stores to fall back on. And so that's why it's important. And compared to adults, babies and small children need even more iron and zinc per pound body weight than adults. Now, again, throughout this entire talk, I'll be talking just about healthy term babies. So of course, if we have a premature infant, then all of these age requirements are going to be shifted. So if a baby was born 2 months premature, at their 6 months of age, they're still not 6 months corrected, they're 4 months corrected, right? So, so they may not be developmentally appropriate at 6 months old. So we need to make sure that we're looking at corrected age when it comes to premature infants. So here we've got the concentrations of iron and zinc in breast milk. And this is, again, term breast milk. In pink, you can see the zinc content in breast milk. And this declines over time, kind of plateaus around 6 months postpartum, although it's quite bioavailable. Now, iron is listed in the yellow bar, and it's never really high to begin with, but again, very bioavailable. So meaning that it's very easily absorbed by the body. I get asked a lot all the time, can we boost up the concentration of certain nutrients in mom's milk by changing her diet? And unfortunately, for the most part, it really doesn't work this way. There's some very, very few exceptions when looking at some high dose supplements of vitamin D, you can get there. But for most other nutrients, you really, really can't just change mom's diet. I tell them, I wish I could tell you, especially our moms in the NICU with premature babies. And I was a NICU dietitian also for about 15 years. And so many of those moms, we would need to provide extra calories to their babies for. And I would tell them, I wish I could tell you that you could go have some pizza and milkshakes and that would produce higher calorie breast milk, but the body just doesn't work that way. But what we do know that is by 9 months of age, about 90% of an iron and zinc needs to be provided by complementary foods because they're just really not getting it from breast milk anymore. And again, so this is looking at this 90% really is mostly looking at human milk fed babies. But as I'll show you some data in a moment, our formula fed babies or even our mixed fed between both human milk and formula fed babies, they're not off the hook. So in the US, we know that about a quarter to a third of all toddlers 1 to 3 years old have depleted iron stores. 15% actually have iron deficiency, and about 8.5% of 1 to 2 year olds have iron deficiency anemia. What we know too, though, is some reports coming out showing that iron deficiency, even without anemia, can contribute to long-term social, emotional, and cognitive developmental outcomes. And that's even despite complete correction of iron deficiency before 2 years of age. So there's really some long-term morbidities that are associated with this. Now, we've already mentioned a little bit about the importance of brain development and the link to iron. And where that comes into play is with the myelin, which is that insulating layer around the nerves and forms those connections between brain cells, between the neurons. And you need iron to make myelin. So these first couple of years of life are extremely critical because the infant's brain is building more and more of these neuron connections than ever throughout their lifetime. So the next slide, this is one of my favorite slides of my talk. So just kind of clue back in here for a take-home message when you see here the synapse density over time and how rapidly the baby is forming these synapses in the brain in that first 2 years of life. And you can tell here again, so think of the importance of iron for making this happen. And then again, that at 2 years of age, they actually have more of these neuron connections than even into adulthood. And so if they're not building as many of these neuron connections by 2 years of age, they have even less to fall back on into adulthood. So it is really such a very critical time to have iron in the diet to help be forming the myelin to help these neuron connections. So that's our link to iron and brain development. Now, unfortunately, over time, we've seen that the number of infants at risk for inadequate iron intakes has doubled. So about 20 years ago, compared to even the FITS data, again, from 2016, shows that about 20% of infants 6 to 12 months of age do not meet their iron recommendations. That's based on the estimated average requirement, which is the dietary reference intake value that is for estimating for the population to meet the needs of 50% of the population. Now, the dietary guidelines also specify human milk-fed infants and look at the RDA, showing that in the United States, about 77% of 6 to 12-month-olds fed human milk have inadequate iron intakes. So this highlights again the importance of introducing iron-rich foods starting at 6 months of age. 3/4 of our kids who have human milk, and not even exclusive human milk fed diets, but are consuming some formula even at 6 to 12 months of age, still have inadequate intakes. Now, a report came out just a couple of years ago that started to take into account iron absorption factors. So this is a really critical way because this is what's actually happening in the body. So they coded foods that babies ate from that FITS data from 2016, and they calculated how much was actually absorbed from those consumed intakes. So it wasn't enough that like you read on a label of a food package and you see that, oh, this has like 2 milligrams of iron. Great. Of course, that's not all being absorbed. And in fact, 50% of the iron in breast milk is absorbed. And so that's what we mean by it being very bioavailable and very highly absorbed. Now with iron is unique because we have heme iron and non-heme iron. Heme iron comes from animal products. So it's the iron in meat, especially red meat. And this is very well absorbed at 20%. In comparison to non-heme iron. Non-heme iron is only about 5% is that absorbed. This comes from grains, infant formula, vegetables. So when we talk about, yes, spinach does have iron in it, but only 5% of that spinach and iron is being absorbed compared to 20% from an animal product. So there's differences in these absorptions. And then when they compared that to what babies were getting, on the left-hand side in the green titled bar, this is the percent below their EAR, their estimated average requirement, not receiving, not meeting their iron needs. Before they did this calculation, about 20% of all infants at this age range were not meeting their nutrient needs for iron. Looking at purely breastfed babies, 82% are not meeting their iron needs, and even mixed fed and then formula fed are listed there. Compare this to once they did this absorption factor calculation and really reflected of like what's actually happening in the body and not just taking all iron sources as equal because they are not equal, then they found that about half of all babies are not meeting their iron needs. Virtually all breastfed babies do not meet their iron needs at 6 to 12 months of age. But even mixed fed, getting both human milk and formula, 3/4 of those babies are not meeting their iron needs. And even, like I said, even those completely formula fed babies are not off the hook. From 6 to 12 months of age, 20% of them are still not meeting their iron needs. So what is also happening around this time period and what's happened over time? Well, as we've reflected on before, we've seen a dramatic increase in the number of infants falling short on their recommended intake, now at least about 20%. And when we look though at what else is going on, infant cereal is what's listed in the purple bars there. And over time, it has declined. And since 2016, it's declined even more among recent concerns about arsenic in rice cereal. So this, even though it was a non-heme iron source, it was a very commonly used introduction and utilization of use of a complementary food for babies. So that's been going down over time. So that's iron-rich infant cereals going down, but it's not really being replaced by any iron-rich resources like beef or other meats. So you can see in the yellow bars, the intake of beef has really remained the same over time. It has not increased to account for matching those displacements of losing those iron sources from infant cereal. Now in the green bars, you can see too that breastfeeding has increased over the past couple of decades. And so everybody would be very excited about that. But we know too that our human milk fed babies are at even more risk because the iron content of breast milk is just quite low. Like I said, even though it's very bioavailable, but for the 6 to 12-month-old baby and their size and how much they are rapidly growing, human milk is not keeping up with that need either. And the dietary guidelines from 2020 recognize this as well, saying that iron-rich foods such as meats and seafood rich in heme iron in particular, and iron-fortified infant cereals are important components of the infant's diet from 6 months old. So again, the recommendation to start those foods at 6 months of age, and importantly for supporting neurologic development and immune function. They also mention about how babies are born with those liver stores that are only useful for about the first 6 months of life. And then after that, infants do really require an external source of iron. Now I'll switch a little bit to zinc as well. The story is similar, but not quite as terrible, I guess I would say, as iron. Only about half, instead of 3/4 of 6 to 12-month-old infants in the US fed human milk have inadequate zinc intakes. And so the dietary guidelines also state that prioritizing zinc-rich foods starting at 6 months of age, again, to complement human milk feedings will help infants meet these requirements for zinc. They also recommend, zinc and iron often go hand in hand with similar foods, meats, beans, zinc fortified infant cereals. And again, they're important from age 6 onwards. We know that zinc is important for growth and immune function. The same authors who did the report looking at the absorbed iron in infants also ran the same process for absorbed zinc. There is a difference between the bioavailability and absorption of breast milk to other foods, but zinc doesn't have the same situation. There's not heme zinc and non-heme zinc in the same way that we have heme iron and non-heme iron. So for all food products, animal products or plant products, they're all absorbed about the same at about 30%. But breast milk is absorbed at about 50%. So there is still much more absorption taking place from that breast milk source. So they compared the zinc requirements to what the zinc intakes were and found that 91% of breastfed infants ages 6 to 9 months old did not receive enough zinc to meet the requirements for optimal growth and development. This decreased to about 33% at 9 to 12 months of age. Probably because they're receiving, even though they're human milk fed, they're receiving even less human milk and increasing on their complementary food sources. But that 6 to 9 month old window where 91% of breastfed babies aren't getting enough zinc for growth and development, that is a critical window. And when we know that meat really isn't introduced until 9 months of age, instead of that 6 to 9 month age period, we're really missing that critical window, even of just 3 months, to get more zinc into these babies' bodies so that they can have optimal growth and development and immune function. Okay, I'll switch into our second major topic. I could go on about different other nutrients of concern. Calcium is also really important, potassium, several other needs, but really the two most critical needs are iron and zinc, and those are reflected in those dietary guidelines as well. Moving into food allergies though, because I think a lot of physicians and pediatricians, and even, even if you don't work in this population, but you are still asked a lot of times about areas that are not within your exact realm of experience, and everybody's always asking about babies, and food allergies is something that has really changed in the past 20 years. We now have records showing that about more than half of kids with a food allergy have no family history. And so this is sometimes very difficult to predict. The rate of food allergies of certain foods has almost tripled in recent decades, and now 1 in 13 kids have a food allergy in the United States. There's serious implications. It impacts a lot of children and adults. Every 3 minutes, a food allergy reaction sends someone to the emergency room. And this is what parents are mostly terrified of. This is why parents also report that they don't let their kids participate in school lunch programs, that they are going to pack their lunch and make sure that their child knows that they can't share and trade items. This is why a lot of parents also report not sending their kids to summer camps because of fears of food reactions, even not sending their kids and letting their kids do sleepovers at somebody else's house out of fear of severe food reactions. And it is very costly to our society, about $25 billion a year spent on healthcare for food allergy and problems. And about 40% of kids have had severe allergic reaction, including vomiting and diarrhea, coughing and difficulty to breathe, swelling of the mouth or throat, or hives. How we used to do it is by an avoidance strategy. So the recommendations from 20 years ago were to totally avoid everything, especially egg, cow's milk, and peanut products. These were to be avoided during the first 1 to 3 years of life. We counseled pregnant mothers to cut particularly peanuts out of their diet. We counseled nursing mothers to eliminate these products from their diet if there was already a history of food allergy in their family. And this did not work. And a lot of research reflected and showed some different populations who had better allergy outcomes because they weren't following this guidance. And then that led to some of these studies here that I've just listed here. If you want more information, you're more than welcome to go search them out on your own. But the LEAP study found an 80% reduction in peanut allergy. That started as young as 4 months of age in some of the babies in that study. It was mostly started around more 6 months of age in that study, but an 80% reduction by starting early. And the EAT study looked at multiple allergens. They looked at peanut, cow's milk, and egg allergens, which are the top 3 most common food allergies in children. And they also looked at a lot of babies and found a significant reduction in food allergies compared to controls. The PETITE study also looked primarily at eggs and found almost an 80% reduction in food allergy reactions. So because of all of these, virtually all of the national guidelines have adjusted and adapted the recommendations of peanut products, dairy products, not cow's milk though, because that's still not appropriate, but and eggs be introduced as early as 6 months, and for some babies even earlier. So you might be scratching your head trying to figure out how are we going to help our families implement all of these strategies, and that's where I have some more practical information for you. So again, helping families start with low allergy risk foods, pureed meat, like I said, ground beef is an easy one to do, those infant cereals that are iron and zinc fortified. And you really do have to encourage families to read labels for that, because not every infant cereal, just because it's labeled infant cereal, does not mean that it has iron and zinc added to it and is fortified with that. In fact, there's more and more products that are being marketed as natural, or, we'll make your baby food just as you would do it in your kitchen, which means they are not fortifying it, because we don't have a chemistry outset over here where we're adding iron and zinc citrate. And even though that's what babies need, and that's what fortification strategies are supposed to do, but more and more of those products are becoming on the market, and parents do not understand the differences. So they just see infant cereal and they think that that's what they're looking for, but many of these products do not have iron and zinc anymore. But other things, pureed fruit, pureed vegetables. The AP still does recommend starting one new food at a time. Again, that's to assess for allergies. So you would look for any reactions like diarrhea, rash, or vomiting. Wait a couple of days before starting another food, and then move on again. Like I said, there's no scientific advice to scientific evidence to start vegetables before fruits. Basically, we want to encourage a variety of foods and a variety of colors. I just recently had a friend. This was about a year ago. She had a baby, and baby was about 6 months of age. And she called me kind of so frustrated one night, about 10 o'clock at night, saying, Kelly, I don't know what to feed my baby anymore. I've fed them butternut squash, we've done carrots, we've done sweet potatoes, and I just don't know what else to do. And I, wanted to make sure, okay, remind me, we're good friends, but in this case, like, remind me, it was a term baby, totally healthy, no other problems. Has doctor said anything else? Like, is there anything else that we need to be worried about? Any other things? And, everything was fine. And I said, well, why aren't you, some green beans or some pureed ground beef or some avocado or banana or applesauce? Like, I mean, there's so many options. And she said, no. The doctor had told her to feed through the rainbow, go through the colors of the rainbow and start with orange and start with vegetables. And she didn't know what the next color should be. And she didn't know when she could do orange fruits. And she just got totally stuck. And so, bless her heart, I think probably that doctor had very good intentions and had, because we talk about like eating a colorful plate all the time, and we want our babies to be eating lots of colorful foods as well. But something got lost in translation there. And so, even though the doctor had a great message for her, it was not. The health communication broke down, so that is just a reminder for all of us to make sure that we're really being clear with what these recommendations are to our families, because sometimes things get misconstrued that way. Anyway, for moderate and low risk infants around 6 months, again, go ahead and start adding in these allergenic foods after a few other solid foods have been introduced and tolerated. So that's the advice, so go ahead and start with some pureed butternut squash and carrots, if you like, add some green beans, add some ground beef, all of that. And then let's start our first experience with a little bit of scrambled eggs. And then introducing them over time. So you have to keep up with them. You can't just introduce them once at 6 months of age and that's a check mark, and now my kid won't have food allergies. No, it doesn't work that way either. We have to continue to build up that tolerance to those allergenic foods. Now, kids with high risk, so those who have already demonstrated significant intolerances to different types of infant formulas, maybe you've had to go through different changes for finding a formula that the baby will tolerate, or maybe there's a sibling who also has demonstrated food allergies, or a parent with significant food allergies. So that's who we're categorizing as high risk. The research says to go ahead and start those allergenic foods at 4 to 6 months, and maybe even that first time specifically for peanuts in the physician's office. And so just to be as aware as possible and help to put those parents' minds at ease. So that might be something that can be done in the pediatrician office. So some other strategies for how do we introduce dairy, peanuts, and eggs. So for a dairy presentation, we want to be having dairy foods. Again, we don't want to introduce cow's milk before the first 12 months of life for other tolerance kind of issues, but we do want to introduce dairy foods. And so helping your parent understand the difference between not cow's milk, but dairy. So yogurt, sour cream, Greek yogurt, cottage cheese, ricotta, there's shredded cheese, all kinds of ways. And one thing that toddlers do really love are dips. And so you can make a dip by blending beans like black beans together with plain yogurt. Now you've got a dipping sauce for some steak strips, for some little baked chicken. You can even some like plantain chips or something like that that are softened or So not like hard chips, but softened banana pieces. And that can be a dipping sauce. You can substitute different beans. You can, and you should like give them lots of different varieties. Different beans are going to have different nutrient sources too. You can use chickpeas and make a hummus. You can use all different kinds of beans. You could use different types of dairy foods too. So one day you've got plain yogurt. The next week, maybe you buy some Greek yogurt. The next time you use sour cream. The next time you might, like I said, have some ricotta or cottage cheese that you blenderize together and down. And so these are ways that you can utilize as an introduction. And like I said, because we need to be introducing these foods and continuously eating them 2 to 3 times a week in order to be building up the tolerance that's needed for the allergenic protection. Another food that we need to be concerned about is eggs. And the food reaction to the eggs is the protein that's of the egg whites. And so some people think, oh, I'll give the egg substitute or something like that, but that's important. That would be helpful for this period, but if you're allergic to eggs, then you can't have the egg substitute either. So scrambled eggs or boiled eggs, chop them into different shapes. The wedges are really helpful, especially for kids to pick up with their hands a little bit easier when they're younger. But different shapes help a lot. You can also make scrambled eggs. You can make scrambled eggs into like a little strip, a little log of scrambled eggs, so that it's not just pieces. And again, it's a little bit easier for the younger ones to pick up. But again, we kind of want to be looking at colors on our plate is important, like we've been talking about too, but different textures and advancing that as well. And then finally, for peanut protection. So another dip that you can do is, and tell your families about, is taking some smooth peanut butter, mixing that half and half, 50-50 with some plain yogurt. Again, you can go for the Greek yogurt, sour cream, that whole list that I already talked about. And now you've got a nice little peanut, but also dairy dipping sauce where we're introducing, we're really tackling both of those allergens. You would never want to give just a spoonful of peanut butter or put a big, glop of peanut butter on a tray. That's a choking hazard. You know how that peanut butter reacts in your mouth too. But this is another great dipping sauce. I also recommend sometimes using the protein source for your dipping sauce. I've had a lot of parents say that, kids love the dips more than the vehicle that they're trying to get the kid to eat, and that they'll just like suck all the dip off and go back for more, whether that's ketchup or different dip or something like that. And that's, this is a handy thing for it to be the vehicle, but also keep in mind, it doesn't always have to be steak strips or baked chicken or things like that, because if you actually utilize some crackers now and again, the crackers won't stand up to those dips. And so the cracker itself will disintegrate over time, and then they'll be eating the cracker too. And so again, it's just a variety of things. We want to provide a variety of different foods to our infants and making sure that they have those. Now I've listed peanut butter puffs on here as well. These are, they look like little, they kind of look like the carrots in this picture, but those are carrots, but they look like little like Cheeto snacks, but they have peanut butter in them, and they're specifically designed to help be another food source for this age group to help with peanut allergies. So those are available. They used to only be available at Trader Joe's, but now they're widely available in Walmart and your other regular grocery stores. They're available online, and so they're pretty easy and again, kind of a more convenient source. And if that's what fits into some families' financial situations and lifestyles, then that's a great resource as well. Advancing textures is something that as a dietitian I hear and see a lot about, that parents just kind of get really relaxed into where they're at, and they don't keep pushing things because it's easy and they're tired. And so, but it's important. So we could take like a product like pureed beef or anything else, and we can mix that with a little bit of, you could mix it with breast milk or infant formula around that 6 months of age range, and you really want more of a loose wetter consistency to start with. But by 8 months of age, you can have a little bit more chunkier ground beef product. And then on the far right, you can see by 8 to 10 months of age, we don't need to continue the puree products anymore. We can move on to things like shredded beef, things that are very soft and easy to chew. And then even by 10 to 12 months of age, continuing to advance those textures to maybe even a chopped product. Baby-led weaning, I get asked about a lot. Basically, the difference is traditional feeding sources would be to start with purees and advance through, whereas baby-led weaning, a lot of people think skips purees, but it doesn't, because purees are still a texture. But in feeding purees, it would be for the parent to or caregiver to load the puree onto a spoon and then put the spoon down for the baby, so that the baby is developing those motor skills by grabbing the spoon and feeding themselves, even with a puree. But it's to encourage healthy eating habits. A lot of baby-led weaning focuses more on exploration of flavors and textures. I still want to be careful about choking hazards and things like that. We're still going to, of course, supervise a child, but it's really an easy way to have the baby be able to eat the same foods that are on the rest of the dinner table for the rest of the family. And then what I tell people basically is, don't make this harder on yourself than it is. And so if you have a time, a certain day, maybe you're going out, maybe you are doing some things with other families or something, and jars of baby food where you're going to spoon feed the child and give them a pouch or something like that is more convenient and fits better into what is happening in your lifestyle in that moment, that's fine too. If you're in another situation where you're able to do baby-led weaning and have an experience where they're going to be more messy and that's going to be just fine, then do that. It doesn't have to be an all or nothing kind of situation. So there's lots more freedom in this. And we all at the end of the day just want our babies to be eating nutrient dense foods that are healthy for them, to go ahead and start these healthy habits starting from this very young age. The palmar grasp is what's developed by 6 to 9 months of age. So if you're doing baby-led weaning, then the pieces need to be cut into these longer strips, like a steak strip, like a long slice of avocado, like a longer piece, like I said, the scrambled eggs that's shaped into a longer piece. And then after that is when they develop the pincher grasp around 9 months of age. And then that's when they be able to pick up smaller pieces of food. Taco Tuesday is all about textures too. So we can start off with more pureed meats, mashed avocado and pureed by 7 to 10 months of age, really encouraging these parents, because a lot of times, again, it's so easy just to get, kept in your same little comfort zone, but we really do need to be encouraging families to progress on these textures. And another thing to remember and help them out with is that it only takes about 1 to 2 ounces of meat per day to meet their iron and zinc requirements for 6 to 12 months of age and even up to 2 years of age. So that's just like 1 or 2 small little meatballs that we've got here is 1 to 2 ounces of meat per day. So we've got a parent's plate with some breakfast meatballs, some scrambled eggs, avocado and fruit, and then you can see the toddler plate next to it too, with that little the scrambled eggs, just 1 meatball, and that's throughout the day. So if they don't finish the whole meatball in the morning, totally fine. There's so many more opportunities to get into their tummies some nutrient dense foods. I get asked frequently too about vegetarian and vegan families. And what I say to them is it's all about intentionality. So absolutely well-planned vegetarian and vegan diets can be helpful at all stages of the life, including infants and toddlers. But I make the connection to the parent, and especially if they themselves are vegan and vegetarian, you know how you have to be intentional about planning your diet to make sure that you're meeting all your nutrient needs. You cannot just be a healthy vegetarian who eats a few nuts and Doritos. Like, that is not a healthy vegetarian or vegan diet. So we would want a healthy vegetarian and vegan diet for your child as well. And then reflect too that their nutritional needs are not the same as the parents, that that they're not just little adults, they have an entirely different nutritional needs. And so it's all about just being intentional and mindful of that. And so that's really how I make the connection with them. We do know that there's been some case studies of severe injury and death, even among infants fed a very strict vegan diet. And so that's infants who have been taken off infant formula, they've been given almond milk and maybe like 2 other foods and had severe malnutrition. Most families are not going to be that way, but it's important to have hands-on education and monitoring of that baby. And then talking with those families, how do you make sure that you're intentional and making sure that your baby is getting all of the foods to meet their nutritional needs? Let's talk about zinc. Let's talk about iron. When we talk about iron, let's talk about the fact that vitamin C foods enhance iron absorption of both heme and non-heme iron. So the iron that they're getting from the spinach, from the beans, from the lentils, from the other foods, by pairing it with a vitamin C source like tomatoes and squash and oranges, of course, citrus and other vitamin C foods, that can enhance the iron absorption as well. Things like sunflower butter is higher in vitamin E and iron than peanut butter or almond butter or products like that. We can still introduce allergenic foods like peanuts, if they're open to that, if they're open to cow's milk in the form of yogurt, if they're vegetarian, we can introduce that. If they're not, we can at least try to get some soy yogurt or products like that into them as well. So it's a very important conversation to have with this population. And really for me, it's about building trust, as you would, of course, with any of your patients, but they have very specific needs and they have specific concerns. And so I never shy away from talking with families about how they can plan a vegan or vegetarian diet for their children. So in our last few minutes here, we're wrapping up. So some take-home messages for you today is to help your families make every little bite count. We want to choose nutrient-dense foods that provide big nutrition for tiny tummies. And it was great to see that the new dietary guidelines for 2020, again, those were the first ones to ever acknowledge that children under the age of 2 eat, and that we would need to provide some nutritional recommendations on a national level. These all align with the AAP recommendations, with other national recommendations as well, for starting solids around 6 months of age. The AAP and the dietary guidelines also do focus on iron and zinc because so many infants have inadequate intakes. These are such important nutrients for growth, neurocognitive development, and immunity. But there are different absorption levels, in particular for iron, and that critical window starting at 6 months of age to develop the neurocognitive development that they need to have is extremely important. And then talking about introducing potentially allergenic foods, also starting at 6 months. And again, once shown they're tolerated, then repeating those 2 to 3 times a week to continue to prevent the allergy. And this can easily be done in combination with iron and zinc-rich foods. So if you just focus on the iron and zinc-rich foods and the allergens, then that's a great starting point. And then from then on, you can start to add in extra things like the avocado and all the other wonderful foods that we enjoy as families. All right, well, I've talked about a lot of opportunities and a lot of hardships, but I leave you with this quote, and here's my uncle out on our cattle ranch pasture as well. Opportunities missed by most people because it's dressed in overalls and looks like work. Hopefully this doesn't seem like too much work to you, and hopefully that you can enjoy some of these, be able to recommend some of these guidelines to your families as well. I think we have some time for some questions if there are any. Let me see here. I just have a thank you. All right. Well, we'll leave it on for another minute or so.
I don't think we have any questions, but thank you so much, Kelly, for the lecture. It was really, really informative.
Wonderful. My pleasure.
Thank you everyone for participating in the Oklahoma Osteopathic Association's 123rd Annual Convention. If you have any questions for the staff, please feel free to contact them at 405-528-4848. And please allow 2 weeks for your hours to be uploaded to the AOA and the OOA databases. Hope everyone can enjoy some nice weather today. Thank you. Thanks.